Now let's look at drugs for angina pectoris. Now, I have heard people say this multiple different ways. So I'm not sure in your part of the country, I've heard everything from angina to angina. So however you want to say it, I just usually say chest pain. But the official diagnosis is angina pectoris, or however you want to pronounce it. Now, there are 4 families of anti-anginal agents. These are drugs that we use to treat chest pain. So as we're starting to look at the drugs, I just want you to tell yourself, hey, listen, there are only 4 families or groups of drugs that we're going to talk about in this video. So let's look at the first one. It's the one that everyone sees on TV, right? We're going to look at organic nitrates. An example of that first of the 4 families is nitroglycerin. The second of the 4 families are beta blockers, like propanolol, metoprolol. Those both end in olol. Remember, that's a clue when you're studying medications. The generic name of beta blockers have that olol response. Next is calcium channel blockers. One example is verapamil. So that will help us also in treating chest pain. So we've talked about the first 3 families: nitrates, beta blockers, and calcium channel blockers. Now, you probably heard of nitrates before you watched this video. Beta blockers, if you've looked at our videos on hypertension, we've already talked about those, as we have calcium channel blockers. But we're going to talk a little bit differently about the application of these medications when we're talking about treating chest pain. The 4th group may actually be the newest to you because it's the newest to us. Ranolazine. This is a new drug and it's got some limited indications, but when it's used appropriately, it can be quite helpful. It's now approved as a first-line therapy for chest pain. So it's moving up in the ranks. We usually combine it with other drugs. So there you have it. Before we start rolling into this, you've got the framework to look at. You can tell yourself there's 4 families of drugs that we use for chest pain: nitrates, beta blockers, calcium channel blockers, and ranolazine. That's all there is. Now let's break each one of these families down. Now, with angina pectoris, there are 3 types. So we talked about 4 different types of drugs that we use to treat chest pain, but I want you to focus on the concept of 3 different types of chest pain. They have different causes. They all 3 hurt, but they have different causes. And so that's what we want to focus on so understand why we treat them just a little bit differently. Now, you've got prinzmetal angina, which is also known as variant angina. So write the word variant above that first red box. Those are caused by vasospasms, where the vessels just literally spasm. They clamp down, which is why it's in a supply ischemia. Supply means we're having a supply issue. There's not an appropriate amount of blood getting to the heart tissue. Ischemia means there's still hope. If we can educate our patients and we can intervene quick enough, hopefully we can restore blood supply to that tissue and keep healthy heart tissue. Now, the next 2 are similar, but I'm going to walk you through how it's different. Chronic stable angina is usually caused because they've got some coronary artery disease. Those arteries are kind of filled up with some plaque, and that means they did something, chronic stable angina. In my part of the country, this always happens in the winter. We see a lot of cases in the ER where we get a random snow and somebody gets the bright idea to go out and shovel their driveway for the first time in years. So they really exert themselves. Well, because of that extra activity, that extra demand that they've placed on their heart, they end up having chest pain. That's because they don't have fantastic blood supply to their heart. But for normal daily life, it's okay. But then when they go and do the manly thing and try and shovel their driveway, they end up putting a greater demand on their heart. And that's why chronic stable angina is considered demand ischemia. Now, the last one, they've cleverly placed a triangle for you there with a big exclamation point in it. You can further circle and star that, whatever format works for you, because this isn't a medical emergency. This is a life-threatening emergency. When we say unstable angina, now this is someone who maybe had chronic stable angina or maybe did not, but at this point it's caused by a thrombus. That means a clot. So if they had some coronary artery disease, something broke off, traveled through the blood supply, boom, Now it's just become a plug or a stopper. And so this is something that needs huge attention, right? This is someone who goes straight to the front of the line. They come in an ambulance, or if they walk into our ER and they show us these signs and symptoms, they get taken right back to a bed immediately, because it's a supply ischemia that's going to quickly turn into infarction if we don't intervene. Because we don't just have a spasm like we do in variant angina. We don't just have a demand ischemia, where if I can get you to lay down and relax and just take some simple medications, you're probably going to feel better. This is, oh my goodness, the blood supply has been cut off to the heart muscle. This is an emergency, because we've got to do something significant, because it's a supply issue that cannot be fixed unless we deal with that clot. Okay, now this is to our friends, the beta blockers. Look at this. We've got a football player up there. That's an American football player that they can view as like a linebacker blocker. So it's labetalol, propanolol, atenolol, metoprolol. Those are all some of the olols, examples to help you start to get the idea that that's one way you can remember what beta blockers are. They end in that olol ending. So how do they work? Well, beta adrenergic blockers is the same thing as a beta blocker. We're talking about the receptor. Remember, beta adrenergic receptors, their job is to respond to sympathetic nervous system stimulation. So a beta blocker is a medication that fits into that receptor, but it blocks that response. So if a patient is taking a beta adrenergic blocker, or beta blocker for short, it's going to prevent the stimulation of that sympathetic nervous system and give us the action that we want. See, it blocks the action of the catecholamines. I know you've heard of these, like epinephrine. Think of it like an adrenaline. Norepinephrine is another catecholamine at these beta adrenergic receptors. Because in a healthy body, here's how it works. Say you're afraid, something happens, your body kicks into high gear. Your adrenal medulla squirts out these substances. They race through your body, they hit the receptors on your heart. They make it pump harder and faster. That's what norepinephrine and epinephrine do. But if I'm taking a beta blocker, then I've got a drug that's already comfy, all cuddled in on that beta receptor. So when those catecholamines get squirted out in my body, they race all around, but they cannot bind to the receptors on my heart. So therefore, my heart rate is lower and it's not pumping as hard. That's what beta blockers do. They block that reception. They are medications that fit perfectly onto those beta receptors, and they block those receptors from being activated. And receptors that are blocked means you'll get the opposite response. Now, in case that didn't make sense, we'll go into that again. So don't worry if it's just starting to settle in your brain. I promise you we'll get there. See, beta-1 receptor sites are predominantly in the heart. Norepinephrine and epinephrine are the substances that come out of the adrenal medulla, and here's what happens when they squirt out norepinephrine and epinephrine. The SA node of the heart, that's the pacemaker of your heart. When those beta receptors receive epinephrine or norepinephrine, the SA node goes faster. And the AV node of the Purkinje fibers, they also increase their conduction velocity. So what happens is the SA node as a pacemaker goes SA node, AV node, Purkinje fibers. That's how a beat goes through the heart. When you receive norepinephrine and epinephrine into those receptors, zoom, it goes through faster. So your heart rate is faster, and the atrial and the ventricular muscles increase in velocity and conductivity. Well, those are a lot of words. All that means is your heart is going to beat faster and much stronger and harder, which is a good thing, because if my sympathetic nervous system has been stimulated, I'm likely in danger. There's a reason my body is perceiving that I'm going to need to run really fast. So I'm going to need oxygen, I'm going to need that heart pumping fast, and I'm going to need lungs that bronchodilate. Now, bronchodilating is a job of the beta-2 receptors. Now, an easy way that I remember this is that beta-1 receptors are on your heart, and I have one heart. Beta-2 receptors are on my lungs, and I have 2 lungs. So that's how I keep track of where beta-1 receptors are and where beta-2 receptors are. So they get hit with epinephrine from the adrenal medulla, and then what happens is the arterioles dilate in the heart, the lung, and the skeletal muscle. Hey, that's cool, because the arterioles are like the control valves. So they're going to dilate when those messengers, epinephrine from the adrenal medulla, hits the beta 2 receptors, arterioles dilate. Now things are opening wide up. Those bronchi, they're dilating because they know we need more oxygen because we're going to need to run. Think of it as running. The same response happens when you get stressed out, emotional, or mad, but just think of it as if you're going to need physical ability to run. Now, the uterus relaxes. That may seem kind of odd. We're talking about it right here, but let's think about it. If I was trying to run away from something that was trying to kill me, I don't want to drop a baby here. Also, it'll relax my GI tract because I don't want to drop anything out here. So what happens is my gut slows down, my uterus relaxes so it won't push out a baby. Now, what are the odds that this is going to be happening? Not really strong, right? That's just a funny way for you to remember sympathetic nervous system stimulation. Arterioles, they dilate. Bronchi dilate because I need more oxygen. My uterus relaxes because I don't want to drop a kid. And then glycogenolysis in the liver. See, the body is so amazing. It picks up that you need more energy, right? Because if I'm getting to, trust me, if I'm going to run, I need a lot more energy. So glycogenolysis is your body's way of breaking out that stored glycogen into glucose. So remember, when you have excess glucose in your blood, your body takes it in, stores it in two places, predominantly your liver and your skeletal muscle. When your sympathetic nervous system is stimulated, it's amazing that your body knows, hey, break out the stored stuff. Right? Genolysis. So lysis, breaking apart. Glyco, standing for the sugar, and gen, to create. So that's what glycogenolysis means, and it happens in your liver. Okay, so you've got a good feel from this slide. That's a lot of information. Let's go back over it to make sure it's solid in your mind. On one side, we have the beta 1 receptor hearts. On the other, on the beta 1 receptor sites. On the other slide, we have beta 2 receptor sites. So make sure you have solid in your mind. Beta 1 receptors are predominantly on your one heart. Beta 2 receptors are predominantly in your what? Good. Bronchi, blood vessels, and uterus, which is not going to apply to a lot, but I wanted to stick in your mind anyway. So when I get the beta adrenergic blockers, I'm going to look at impacting the jobs of these receptors in your body. Okay, now this chart is really going to be helpful, so just hang with us as we fill these in. Now you'll notice it says beta 1 receptor sites. Do you see that on the far side of your screen? The title of this is Beta Adrenergic Blockers Block the Activation of Beta Receptors! Exclamation point, all right? So this is to give you context about what we're talking about. In one column, we're going to talk about what happens at a beta 1 receptor site when it receives or it binds to norepinephrine or epinephrine, what the response is. The next column will say, what happens, if you've given that patient a beta blocker? So the drug will beat those guys to the beta 1 receptor site. So let's look at that again. Okay, if a beta 1 receptor site binds to norepinephrine or epinephrine, the SA node increases the heart rate. But if you've given them a beta blocker, then the heart rate increase is blocked and the heart rate will therefore decrease. So that's an important point with beta blockers. Their heart rate will definitely be lower. Now let me tell you why this matters. Back before I was able to make some lifestyle changes, I was on 5 or 6 blood pressure medications. One of them was a beta blocker. Beta blockers directly decrease your heart rate. So don't ever try to do physical training with an elevated heart rate when your patient's on a beta blocker. So keep that in mind when you're teaching your patients. Don't do physical activity trying to get your heart rate to a certain level. It's going to be a big problem. You'll do some damage to your heart before someone on a high-dose beta blocker can ever get their heart rate up that high. Why? Because you've got the beta blocker drug on the beta 1 receptor and the SA node cannot respond to the increased demand like it normally would because they're taking a beta blocker. Now what happens at the AV node and Purkinje fibers? Well, under normal conditions, when norepinephrine and epinephrine bind to that beta 1 receptor, the AV node, remember that's the pacemaker, SA node, AV node, Purkinje fibers, bundle of hits, you got all that going on. AV node and Purkinje fibers, it will increase their conduction velocity. So those fibers will boom, boom, boom. those impulses will just be tearing through the heart at a much faster rate, unless they have a beta blocker on board. Then that increase in velocity that normally happens when norepinephrine and epinephrine bind to receptor won't happen. So we know their heart rate will be slower, right? Because the SA node increase is blocked. The velocity will not be as intense, so that's another reason why it won't move through. Now again, if we think about norepinephrine and epinephrine getting to the beta-1 receptors on the heart, the atrial and the ventricular muscle will increase in velocity and conductivity. What does that mean? Atrium, ventricle, atrium, ventricle, atrium, ventricle are going to be like atrium, ventricle, atrium, ventricle, atrium, ventricle. They're really going to be a lot more intense, unless the patient's taking a beta blocker. So then the increase in velocity and conductivity is blocked. It's not going as fast and as hard. So you can see, based on what you already know about blood pressure, if the heart rate is slower and it's not pumping as hard, my cardiac output is going to be diminished. Therefore, my blood pressure will be lower. Okay, so that's pretty cool, right? That's really what we want. If we're treating somebody with hypertension, we really want to go after the beta-1 receptors. We would call that medication a selective beta-adrenergic blocker or a selective blocker. It will just impact the beta-1 receptors. That's usually what we want. But stop and pause for a minute and think. What other beta receptors have we talked about and where are they located? We have beta-1s on your heart. So where are the other receptors located? You got it. Beta-2s are located on your lungs. Good job. Now, before we leave this chart, make sure it makes sense to you. You've got the receptor on one side, what happens in a normal response when the sympathetic nervous system is stimulated. So make sure you've got a note written to yourself up there above norepinephrine and epinephrine response. That's the sympathetic nervous system response. Over the beta blockers, that's what happens when we give them a med. Now let's take a look at our friends, the beta-2 receptors. Yep, you just answered that question about that. So we're going to look at what happens when epinephrine hits the beta-2 receptors and what happens if you have a beta blocker already on the beta-2s. Now I talked about selectivity. Really what we're looking for is more of the selective beta blockers that would just hit the beta-1 receptors. But in all honesty, no matter what drug you're on, either it's a specific cardioselective or beta-1 selective beta blocker, or if you're on one that's non-selective, and it's both beta-1 and beta-2, you could still experience these beta-2 effects. So keep that in mind when we're talking about patient education. So let's look at what epinephrine does. When it hits the beta-2 receptors, remember it dilates those arterioles of the heart, lung, and skeletal muscle. It's in this diagram too because we're talking about the lung. Now, if you've given the patient a beta blocker, it's going to block that dilation. Okay, here's where this becomes an issue for your patients. Any patient that we send home on a beta blocker, we need to make sure that they understand if they have any breathing problems, they need to contact their healthcare provider. Okay, so for you, beta blockers and breathing problems are bad news. Beta blockers and breathing problems are bad news. So if you're on a non-selective, you're more likely to have a problem, but people who are on a selective one that should just go after cardiac beta-1 receptors on the heart still might have this problem. Sometimes they're going to need their lungs to bronchodilate, and that action will be blocked if they're taking a beta blocker. So that's why it's really important that you teach your patients, if you have any breathing problems, please contact your healthcare provider. Then they can problem solve with them and assign a different type of medication. Because when it blocks that dilation of the bronchi, your patient might feel really short of breath. And you don't want that, nor do any of your patients. So you make the difference. Educate your patients that, hey, you may or may not have this experience, but if you notice shortness of breath, you definitely want to do something about that. Contact a healthcare provider, probably not take your next beta blocker based on what the healthcare provider advises you to do. Now, the relaxation of the uterus, this is just kind of a talking point in here, not going to be a major factor when you're taking beta blockers for hypertension. We do use beta blockers for sometimes to maybe slow down the process of labor, but that's not the application we're talking about here. Now, glycogenolysis in the liver, remember that breaks down the stored glycogen when a beta-2 receptor is hit by epinephrine. But beta blockers will block this effect. They will block this genolysis. This can be particularly problematic for diabetic patients. See, a symptom of low blood sugar, which is the biggest risk for our patients that are taking insulin, if someone has low blood sugar, what happens is the body kicks into this sympathetic nervous system response. It tells the liver, hey, when this epinephrine goes around and is circulating, it tells the liver to kick out stored glycogen to try and raise that blood sugar. Here's the problem. If the patient's taking a beta blocker, there's two things it won't do. Normal signs of low blood sugar are fast heart rate, and their body's going to try and break out that stored glycogen into glucose for blood sugar. But if they have a beta blocker, you're not going to have that reaction. So the patient's not going to be able to respond to a low blood sugar as quickly and as easily as they normally would because they're on a beta blocker. And the other issue is you're not going to see the tachycardia. Why? Because if the patient's taking a beta blocker, remember, you don't get that faster heart rate. So patients that are diabetic and taking a beta blocker won't show you the typical signs of low blood sugar. So it's very important that you educate your patient and their family members to know that, hey, if they start to kind of show you some confusion, really check that blood sugar, because you're not going to see the normal signs of fast heart rate, and their body's not going to be able to respond as efficiently by breaking out stored glycogen. Now the last one, enhanced skeletal muscle contraction, which everybody wants, you're not going to have that on a beta blocker. So why does understanding how receptors work and their response help you? Because once you understand how any receptor responds when it's activated, if we're giving any type of histamine, it's going to be the opposite of that response. There's going to be less of that response. See, this applies to antihistamines, right? And instead of allowing histamine to connect to its receptor, then that's how antihistamines work. Beta blockers are the same thing. Antagonist, blocker, antis, that's what all these drugs do, is they block the response of that receptor. Now, since you know what beta 1s and beta 2s do, you can easily remember how the patient will respond. So the non-selective ones block both beta 1s and beta 2s. That's why they're called non-selective. Labetalol, propranolol, those are two really good examples. Now the ones that are selective, these guys are a little newer and a little more expensive. Atenolol, bisoprolol, and esmolol. Okay, but also keep in mind that even if it's supposed to be selective, with certain patients and different times, they may also have beta 2s stimulated also. The goal is primarily beta 1, but it's not exclusively beta 1 depending on how the patient is doing. So let's pause for just a minute and focus on a question. Let's see if you can remember some easy things. Where are beta 1 receptors located? Good, on the heart. Where are beta 2 receptors located? Good, on the lung. Why do I want a patient with asthma to be on a selective beta blocker? Remember, the benefit for being on a selective beta blocker is we're going to minimize the risk of that asthma patient needing to bronchodilate and having that response blocked. So we probably would look for another medication for an asthmatic patient, but any patient that we put on a beta blocker, we always teach them beta blockers and breathing problems are bad news.
So let's take a look at some characteristics in regards to wound assessment. So there's 6 things on this slide, and this is important about how we assess and also how we document, and we'll discuss this further. So of course, when we talk about wound care, we got to know where it is, right? So what's the location when we assess that wound, and what type? There's lots of different types. This could be incision, it could be a laceration or abrasion. It's important to know the type of wound on assessment because that will affect how it heals. Next, we got to think about the type of wound tissue when we're talking about wound assessment, And believe it or not, measuring the wound's really important. That's how we progress if the wound's getting bigger or worse, or if it's getting better. This next word is called exudate. You may have never heard of that, but what we're talking about is assessing the drainage of the wound. That drainage actually tells some really key things in the healing process. And there's that wound again, or that word again, peri-wound. This is the tissue around the wound. And again, this is important to assess. That's going to help keep the integrity of the healing of the surrounding skin. We just talked about the 6 different categories in regards to wound assessment, and I'll take you through each one of these. The first one is location. This is really important that we're specific about where that wound is. So here's a really poor example about describing wound location. Client has a wound on their leg. Well, that's not very helpful, is it? It could be anterior, posterior, we don't know if it's on the upper thigh. This is not a great example about a description on where it's located. So let's take a look at this other slide. This is much better on a description, such as client has a wound on their right distal medial upper leg. That's much more specific than the previous example. So now let's take a look at the different types of wounds. This is going to actually be really important because it's going to determine how we treat it. So this first slide and example you see here is normal skin integrity. That's what we want to see, that epidermis is intact. This is before we get into these wounds. So let's take a look at the next kind. This is an incision wound. So this is usually a clean, approximated edges, and this is typically post-surgery. So this could be on a patient's hip or their knee or their back, for example. The next kind of wound is more of the tearing of the skin, called a laceration wound. This could be from some sort of trauma, for example. Now the next wound that I think about is what we call an abrasion. This is something that takes me back for when I was a kid and I fell off my bike and I scraped up my elbows really bad. This is more of an abrasion type wound. Now the next half, we're going to talk about some other types of wound, and one of those is a puncture wound. This may be not as common, but what this makes me think of is maybe if you work in an ER and you see someone with a knife wound, for example, that's a great example of a puncture wound. Now, a pressure wound is something that you will see most commonly. This is really common occurrence that can happen when the patient's immobile in bed, and the varying degrees of pressure wound can go from pretty mild to pretty severe. Now, the next 2 wounds are a little bit different. So this is called a contusion, and usually the skin's intact. Think of this of more like a bruise. And lastly, when we're talking about types of wound, you may hear the word hematoma. Now what this means, there's a pocket of blood, for example, caused by some sort of bleeding or some sort of trauma. Now let's take a look at different types of wound tissue. So this one is what we see here in this lovely slide. It's called granulation tissue. Believe it or not, it may look a little bit bad, but this is actually a good thing. See how this wound bed is red? This is all nice new tissue that's healing. So this is a positive here. You may also see this different type of wound tissue called slough. Now this is due to the inflammatory process, and this typically means there's some dead cells in here, there's some debris. See how it's kind of yellowish and you don't see all the nice red? That's typically something that we may have to remove in regards to wound healing. And lastly, you see this is called eschar. This may look pretty crazy to you, but this means that there's dead tissue within the wound. So think about it this way. You see on this image, the black is actually setting inside the wound. That's called eschar. Now I want you to think about the difference between eschar and like a scab that you get. What the difference is a scab actually sets on top of the wound, where eschar is inside the wound. So if we're talking about a major wound, eschar may be noted. Now here's the problem with eschar. You may not be able to see everything underneath and what's going on with that wound, so sometimes we may have to remove this for healing. Also, before we leave this slide, I want to go back really quickly to granulation tissue. Here's the thing to note when you're a nurse in regards to wound healing. Believe it or not, we actually want to see that red, that oozy, a little bit of bleeding tissue. Again, nice pink or nice red tissue, as you see in the granulation slide. That is a positive thing for wound healing. That means blood's coming to the surface and we're oxygenating that tissue, which is important for wound healing. Now let's talk about measuring the wound for assessment. This may seem like an odd thing to you, but we do this because this will help us track the wounds. So one thing to note is if you're in an acute care facility, there is something we call the wound care team, and thank goodness for this team. They're advanced certified nurses that are diligent in wound care assessment. And sometimes as a bedside nurse, you may do wound measurement, but a lot of the times the wound care team, if it's a complex wound, will track that wound, and they do that by measurement. So let me show you how we do measurement here. So we usually do it by 3 different things, such as width, as you see here. We'll do the full length of it, and also the depth. So no, this is kind of tricky. So you see that we typically take like a cotton tip applicator. We will put it to the deepest part of the wound, standing up. We're gonna take that cotton tip applicator and compare it to a measuring tape and see how deep that wound. Believe it or not, guys, these can get really deep. But again, using these measurements of width, length, and depth, this is really helpful to track the progress of that wound. And as you see on this slide, many times we'll use a sterile, keyword, sterile cotton tip applicator for measurement and also a measuring tape. Now let's take a moment, and you heard this funny word before, but this is called exudate. This is actually really important in regards to assessment of a wound and what you should expect as a nurse. So see all of these progression of colors? We'll talk about these. So exudate's the fluid produced by a wound again as it heals. Again, guys, this is normal. This is what we should see, is going from that clear all the way to kind of that yellowish at the end. We'll talk about this again more in depth. So we're talking about exudate. This is actually really important to kind of know your exudate here, and we classify about 4 different categories. How much exudate, or otherwise known as drainage, there is, what color is it, what consistency it is, and the odor. So let's talk about the amount. So this is important in documentation and assessment. It can go, if you look at this category, from basically not much at all the way down to copious. That seems like an odd word, but we're talking about copious. It's not just a little bit, it's a lot of extra fluid and probably more than is normally expected for a wound. So copious drainage is not always a positive thing. So again, it goes from none all the way down to copious. Next, we'll look at the color of the wound. These names are very hard to spell, I know, as a nursing student, but get familiar with these because this is how we document the color of the drainage. It should go by serous to sanguinous, so bloody, to serosanguinous, where you get a little bit of clear fluid, a little bit of blood, and then purulent could be a negative sign. Purulent drainage could be discolored, it could be signs of infection, so why it's important to get familiar with the color of your drainage. And next, consistency. This may kind of sound a little gross, but your exudate should be fairly thin. Sometimes it can get really thick or even what we call tenacious if there's signs and symptoms of infection. And next is odor. So know that there's sometimes an odor with a wound and sometimes there's not. Now if there's a foul odor, again, that could be signs of infections that we need to report. Now the next few slides, we're going to discuss each one of these options and show you more examples. So let's take a look at the exudate amount again. So you see here, this is called scant. So meaning there is a tiny amount as you see on this gauze pad. Typically, this is nothing for us to worry about as a nurse. Something we'll keep an eye and to see if it gets any worse when we're looking at a wound dressing. We look at this next one as about moderate drainage, and this next slide is more large. So this gives you a great comparison on the image. So here's that copious. Now I want you to compare the copious to the large. If you have copious exudate, what that typically means, it's saturating through the bandage so much that we're going to have to change that out frequently. This could be a problem when we're talking about an incision wound. We may need to report that to the physician. So now let's talk about color. Color is important here. So initially, anytime that you have a wound, you start out with serous exudate or serous drainage. This is like a light yellowish to clear, and this is to be expected. Now eventually that's going to turn into sanguinous, meaning this is more bloody drainage, and that's perfectly fine as well. Now with more wound healing, we'll have serosanguinous. As you can see, it's kind of a mix between serous and the bloody, why we call it serosanguinous here. So it's more of like a light red, kind of pink or watery here. And next we have purulent drainage. This can be thick in consistency. It could be anywhere from like yellow to tan to green to brown. We want to watch this purulent drainage because if it's really dark brown or maybe really green or really white even, this could be an issue with our incision or our wound. Now let's go on to consistency and odor. So consistency, like we talked about a bit, can be thick, it can be thin or tenacious, and sometimes again, that wound may have an odor, and if it does, we need to monitor this because that could mean there's a complication occurring. Now we talked about the peri wound, if you remember earlier in the presentation. This is the part around the wound, the skin surrounding it. So we need to see, is this red, warm? Is it super swollen? Is it starting to break down around there? If it is, we need to protect this skin integrity, and the peri-wound skin is important to assess. Now, let's take a look at these bullets here. This is some abnormal other key points to know about your wound assessment. And if you see any of these things, this could be a particular issue. So if there's pain or swelling, that's different from when you first assess that wound. If that's getting increasingly different, that could be a problem. Sometimes with wound assessment, maybe a patient has, a wound on their arm. If it's getting excessively stiff, that could be an issue. And we already talked about that drainage. That's really important to note. If it's pussy or if it has an odor, that's definitely abnormal and we need to report it to the physician. Now these last points as well are also abnormal. So let's make sure we pay attention to these. There's a lot of redness around the wound. If your patient's spiking a fever, if the wound's not healing, meaning those edges aren't closing in as we're going through that healing process, that could be a problem. If it's gaping open, that's not a good sign. And lastly, if there's any, here's my wound and it's streaking around it, also a very bad sign, and we want to report all of these pieces to the physician. Now we're moving and we've gotten past our head and neck. Now we're getting to our chest. So here is the portion when we're going to look at the thorax that includes the lungs and the heart. So when we're looking at our lungs, don't forget to listen or auscultate. We're going to get our lung sounds. We're going to see how hard their work of breathing is. Is it labored? Is it fast? What's their pattern and what's their diaphragm doing? Also, when we look at their heart, we're going to look at what their pulse is like and also any sort of heart tones. So now let's take a look at anatomical landmarks. Now these are meaningful points on the body that are the same in all people. Now this is really helpful in describing maybe where we auscultate the heart, for example. So now let's take a look at some really common landmarks that you might run across. If you take a look at this image, you see the black line running through the middle of the chest. Therefore, we call it mid. And of course, you see it running here through the sternum. All the time, we call this anatomical landmark the mid-sternal. Now, in this next line that you see here, notice that first word you see anterior. Now, as a nurse, a nursing student, or any healthcare provider, it's really important that you remember anterior is front, posterior is back. So here we're on the anterior side of the body, so towards the front. And you also see axillary. So anytime you hear that term, think of armpit. So this is the front side anterior axillary line. And of course you have one on both sides, correct? Right and left. Now next, when you see mid-clavicular, think about mid. And you see that root word there in this? It says clavicular or otherwise clavicle. So if you take a look at this anatomical landmark, you find the patient's clavicle and really just go down the middle here. This is what we call the mid-clavicular line. And of course, this can repeat on the other side as well. Now taking a look at this next image, we're looking at a little bit different view here. So we had talked about this before. You remember anterior is towards the front. And of course, as you see here, posterior is towards the back. So this is just the other view of the axillary line, so running through that armpit on the back side of the patient's body. Now next, as you see here, this is another way to look at this, is the anterior side in comparison of the axillary line as well, running through that armpit area. Now also you see here, if you split the difference between the two, especially when you see the patient in a side view like this, in the middle of the axillary or where the armpit would run, we call this the mid-axillary line. Now when assessing the patient's chest and or thorax, palpation is a great assessment method that we can use. Now before we listen or auscultate, we may need to feel the patient's chest and their ribs for asymmetry, but you've got to be really careful here like you see in the image. So as you can imagine, if you assess the chest and you see asymmetry like this, that is not normal, so be careful when you palpate. Now next you may see retractions. Now retractions kind of mean that there's this skeletal-like appearance when you look at the patient's chest, meaning you can see the ribs and part of the chest or the skin sinks in. That is not normal. So asymmetry and retractions are not normal. This can mean trauma or the patient's in respiratory distress. Now let's talk about auscultation of the lungs. This is so important. We're going to talk here on how we actually do the auscultation and perform this. Now please don't forget to compare both sides, meaning anterior and posterior, and the upper and lower lobes. So this is really important, and many times you're going to see this in nursing where you see the nurse just listen quickly and go. Now it's really important that you compare upper, lower, anterior, and posterior because we need to check for what we call adventitious lung sounds. Adventitious is just a fancy word of abnormal lung sounds. So the reason why we want to listen to both upper, lower, back, front, many times you'll actually catch in your pneumonia patients that crackles actually develop in the back and the bases of the lungs. So as you can imagine, setting up and being able to listen to the front and the back takes some strength and mobility of your patient. If they can't do this, you can always just have your patient roll and hold on to the side rail or get assistance and check their posterior lung fields. Now let's talk about adventitious lung sounds, or again, just a fancy word for abnormal lung sounds. Now just think about if you took your own stethoscope, put it to your chest, hopefully you have none of these, and you breathe in and breathe out. You should just hear that normal inspiration and expiration. That's one. Now, if you hear some sort of popping sound or like Rice Krispie, we call that crackles. That usually means there's some wetness or mucus in there, and that's abnormal. Next, you may hear the word of rhonchi. This is more really low pitch, more coarse, kind of like a snoring or a moaning sound, and this is also abnormal. Now, you're probably going to hear rhonchi more on expiration, like inhalation out, than breath in. Now, wheezes are actually pretty common, and sometimes you're going to hear this high-pitched. You can hear this with your asthmatic patients. Sometimes if I run too much, I may start wheezing myself. It's that high-pitched musical squeaking. That's actually abnormal in your patients, and we need to note this. Now, lastly, you may hear the word pleural rub. This really just kind of sounds like two pieces of rubber rubbing together. So again, if you take a look at this slide, all of these are adventitious lung sounds. They need to be monitored, checked for changes, documented, and reported to the physician. Now let's talk a little bit further about breathing. So we talked about what it sounded like, but what does it look like? So it's important here as a part of your respiratory assessment that we got to look at the patterns of breathing they have. So hopefully your patient's just having a normal inspiration, expiration, relaxed, non-labored breathing. But sometimes the patient could have tachypnea, which means their respiratory rate is fast. They're breathing fast. Kind of think about the time when maybe you're exercising and running and your respiratory rate picks up. Now sometimes you can have a decreased respiratory rate, which is the opposite. Now, sometimes this could be normal for the patient, but sometimes it can be so decreased that this could be an issue. This could be because maybe we gave the patient too many opioids and it depressed the respiratory system so slow, this can be dangerous. Also note any sort of apnea or absence of breathing episodes where the patient just truly stops. There's other different kinds of breathing patterns that are important to note. So these are usually not good signs. So you may hear the word Cheyne-Stokes. So this is an gradual increase and decrease with periods of apnea, meaning you're going fast, going slow, and then you have a period where you just stop breathing. That is not normal and dangerous and a sign of something else in respiratory distress. Also, you may hear the word Kussmaul's breathing, which is fast breathing patterns and hyperpnea, which again, this is an abnormal breathing pattern, all of these that you see on the slide, and we need to monitor. Now, when we start talking about assessment, here's a few really important tips to keep in mind as you're working through it. Now, just know as a nurse, there's different ways that every nurse kind of does their assessment. But keep in mind you want to be systematic, meaning you have a method in a way that you make sure you're doing it the same way each time. This way you'll cover all your body systems. Now, one really popular way is what we call head to toe. That makes it really easy to make sure you're hitting all those important body systems. Now, don't forget when we are going head to toe or systematically when we're assessing our patient, you've got to compare sides, right? Because you do have two arms, you've got two eyes, you've got lung fields on each side. It's really important that we compare here because there can be differences. So some examples I'm talking about is like lung sounds, for example. You may think, well, okay, they should sound the same, but indeed, a lot of the times, depending if it's your trauma, for example, they may not. So what I mean by this is, let's say you listen on the right side of the upper and lower lobes of the patient. Maybe they really don't have a lot of air movement when you listen to them on inspiration and expiration. You can barely hear that breath. Now, when you listen on the left, it sounds great. You hear a full inspiration, full expiration. Now that's different, right? From the right to the left. That could mean there could be a collapsed lung or something else going on with the patient, and we need to assess that. And as you can see, right versus left is different. Now here's other really important time that this comes into play. Stroke patients in particular. A lot of the times I used to work on a stroke floor, and as you can imagine, depending on the side of the brain that's damaged, the opposite side can be affected. So you may have weakness on one side of the body. Again, this is where comparing sides is important. And of course, just kind of keeping on the neuro status, looking at the difference of the pupils. There can indeed be some changes on one side versus the other. You could have two different sizes of pupils. Sometimes this is emergency, sometimes it could be normal for the patient, but be sure to compare sides. Now, recording notes when we're talking about organization is really important. As you can imagine, there's a lot of patient data going on. So one key way to do this to make sure you've got the right information with the right patient is recording at the bedside computer if this is available at your facility. So this is really the standard of care. We perform our head-to-toe assessment. We document in the room with our patient. We can have a conversation with them, such as, have you had a bowel movement recently? And this includes the patient in on their care as well. The other thing to keep in mind, if this is not available, think about all of the different patients you may assess. So a great example is maybe I have 5 patients on the medical surgical floor. I can't memorize every single assessment detail on one room, then the second room, then the third room. So it's important that you record notes and keep track of details. So when we're talking about assessment, now there are 4 techniques that we use. Now, what are the 4 basic physical assessment techniques that we use? And these are the big ones. So we call these the big 4, and these are the types of ways that we perform head-to-toe assessment or gain information. So one of those is one of the easiest, which is inspection. Now we kind of talked about this earlier when we were talking about eyeballing and visually looking at our patient. So inspection is great. We tend to underestimate this, but we can see a lot, especially with more experience as you gain as a nurse. Inspection gives us a lot of really important patient condition information. Now, palpation's a little bit different. This is more thinking about feeling with your hands. You're really using your hand in what we call palpate and feel. Now, this is really important. Let's say if you're using an abdominal assessment and we start palpating and feeling, we're going to see, does the patient wince or move away from that pain or seem to be tender when we push? Now, one thing I want to talk about palpation. If you see an abnormality and you're not sure what it is, my recommendation is do not palpate it. So there's certain tumors, especially in the pediatric or the baby population, that you do not want to palpate this particular tumor or mass. If you're not sure, alert your doctor. Now, next is percussion. This one's a little bit different, and you may not see this quite so often with bedside nursing. It just really depends on where you work. So percussion is, as you see in this image, where you're going to tap with fingers or maybe hands to feel around the borders of an organ in the body. Now, you're listening for different timpanis and different sounds here. Now, and again, this is really helpful for specific type of advanced physical assessment, but again, bedside nursing, we don't use this quite so much. And next is where we get to use what we call our ears, otherwise known as our stethoscope. Now, this is the practice of auscultation, meaning we're listening. So we're using our stethoscope here and looking at different and listening to different parts of the body. We can pick up all kinds of important assessment details. Now, one thing before we leave this big four. So typically we use these four things to help us gather information. Just know when you're talking about an abdominal assessment specifically. Now, the order's a little different. You want to look at the stomach and the skin and everything with your eyes and perform inspection. Then we want to use our ears and listen to those bowel sounds. Then we can percuss if indicated. Then we palpate. Now, the reason why we look and listen first, because we start pushing around on your stomach. If you take your stethoscope and take a listen after I've been pushing around, it'll probably you'll start hearing a lot more gurgles and movement, when that's not really the most natural bowel sounds that you should hear from your patient. So when you're talking about abdominal assessment, so look and listen before you touch your patient's abdomen. So now let's look at how we divide up a head-to-toe assessment. And again, every nurse practice is a little bit different, but this is a great guideline to check on your body systems. So if you take a look here at the top, when we look at the head and divide this area, we're looking at the central nervous system, we're seeing their level of consciousness, their orientation, we see their skin, their eyes, their nose. All of this in the head area covers quite a bit. Then if we move from the head down to the chest, we're going to capture our respiratory and our cardiovascular system by listening to our heart and our lungs. Now, if we're just moving on down the body, now in this section, when I think about stomach, I always think, this may sound a little bit weird, but I always think about, don't forget pee and poop. So you're thinking about the GI system, bowel sounds, movement, bowel movements, for example, diarrhea, any of these issues. And then moving on down to the GU system, which is our urinary system. So when I get to the stomach, I just think pee and poo, meaning when's your last bowel movement? Are you having any pain? How's your bowels been? When's the last time you voided or urinated? How did that look? Next, as we've been moving down, don't forget the all-important largest organ in your body, which is the skin, right? So all while we're moving from head to toe, we're capturing all these skin pieces and these skin's assessment as we're moving down and seeing if we see wounds or lacerations or any abnormalities. Now, as we move through our patient, sometimes this can be assessed because your patient may naturally be moving, but we want to keep in mind their musculoskeletal system and their mobility. Can they move their arms and legs? Are they really weak? Do they need assistive devices? And don't forget any IV lines, drains, or tubes as we're moving from head to toe. Hi, welcome to the skill Intravenous Catheter Insertion and Removal. Now, this is a pretty complex skill, so please pay attention and follow along with me. So let's start with what you're going to need. There's actually a good amount of equipment that we need to consider when we start an IV. So first and foremost is the peripheral IV catheter. Now know, with IV catheters, it's going to vary in sizes, so you will have to make a decision about which one is most appropriate. So don't forget, peripheral IV catheters is going to vary in sizes. Also know that each facility has a little bit different equipment, so you're going to want to get familiar with what your facility has. All right, next we need to look at the extension tubing. Sometimes you're going to hear a nurse call this a pigtail. It's a funny name, but a lot of the time if someone says, hey, go get a pigtail, this is what they're talking about. Then we're going to need the Lurlock hub. So this is what's going to connect to your pigtail or your extension tubing. Then you're going to need saline flushes. So again, more equipment. We've got an IV start kit. So the nice thing, all of these pieces are usually bundled together. However, I'm going to talk about those components of that start kit. So first you need an alcohol pad. This is going to help clean the site. You're going to need a tourniquet to hold pressure and also to help visualize veins for you. You also will need a gauze dressing. This may help be there to clean up any mess that you made. And also a transparent dressing. This is going to cover the IV insertion site to keep out those microbes. All right, so the last thing that you see is a stabilization device. Now, this is going to vary from facility to facility. So in this, just know that that's a possibility that your facility may use, but lots of facilities do not use this due to cost and extra supplies. So when we start an IV in any procedure with a patient, don't forget hand hygiene when you come into the room. We definitely want to provide patient privacy because we are doing a procedure with our patient, and make sure that you guys are explaining this in detail to your patient. Now keep in mind, when we are poking or inserting an IV, if you will, anything sharp, any procedure with a patient, there may be some apprehension there, some anxiousness, so we want to be reassuring in this step. And also, don't forget to raise the bed to appropriate working height for you. Luckily, I'm not very tall, but if you were, we don't want to be crouching down or leaning over. We want to get in a position and do a procedure that is most comfortable for you so you can be successful. So once we've done that, we've provided privacy, done hand hygiene, we've explained the procedure to the patient, we want to position our patient, and it's good to place the patient and put their arm in a dependent, comfortable position. Sometimes we may want to support their arm with a pillow if that's also comfortable for a patient. Then you want to prepare your supplies. So you have the option to use a tray table. You could also even put it on your patient to where it's very easy access when you're starting the IV. You'll see that in a few in the demo. Also, before we start the procedure, let's do everything we can so we don't have to basically stop in the middle of what we're doing and we've got our hands tied up. So we're going to attach that Lurlock to the extension tubing, and then we're also going to attach our flush here, and you'll see why later. So we're going to attach the flush, we're going to push the plunger and what we call prime the extension tubing. All we really mean here is we're going to push the saline through the pigtail or extension tubing here. So now, pro tip, if you will leave the flush attached to your pigtail or extension tubing, this will make it much easier for you later when you have to attach it to the IV. So now let's take a live look at how we prepare equipment. I'm going to get some hand hygiene started. All right, so first I've got all my equipment here and of course my patient. So I want to make sure my patient is nice and comfortable. This could be a bit of an anxious procedure for them, so I want their comfort to be really important. All right, so then we're going to take the arm that we decide to select our vein and make sure that arm is in a nice, relaxed, dependent position. So now I can open and prepare my supplies. So if you remember here when we talked about supplies, we've got an IV start kit that contains most of what we need. We've also got our IV catheter, we've also got our extension set, we also have our hub on top of our extension set so we can attach our flush later. All right, so anytime you start an IV, you want to try to make sure all of your equipment is nice and ready, because once you get in there, it's very hard to try to manage equipment and then IV insert. So let's open our equipment first. All right, so most facilities have something looking like an IV start kit. The nice thing in here, when we open, it's got a nice tab for you. You can open this up, and this is going to include things such as your alcohol pad, your tourniquet. It's going to have your extra gauze for you. So when we've opened this up, we've got our tape. We've got our ChloraPrep or alcohol pad. Now each IV start kit's going to vary a little bit, so just know that you will have something to clean the insertion site with. We've got our tourniquet, and this is going to be applied to the patient. Always comes with a nice little rubber band. Let's get this off. Going to unroll this. So this is our tourniquet for our patient. Then inside we've got our transparent dressing as well. So we want to get that out and ready. We've got a gauze pad also inside the insertion kit in case you need to clean up a little extra body fluid or blood. This is also a nice little thing that comes with the insertion kit. This will help go underneath the patient's arm if you choose to use that. All right, so now that our equipment is open, I'm also going to prepare my IV catheter. As you can imagine, if I'm trying to insert an IV, trying to open all of this while doing the IV is not going to be very easy. So let's get all this prepped first. So I've opened my IV start kit. I've got my tourniquet and my catheter ready. Now we're going to prime and attach our extension tubing. So you notice when I'm opening everything, I'm leaving everything in the package. This is going to keep everything as clean and sterile as possible before we apply it to our patient. Now, anytime that you use equipment on your patient, don't forget you want to make sure it's all in date as well, and make sure your equipment's not expired. So I'm going to open this up, and this is our Lurlock or our cap. And this is going to go on one side of the extension tubing. So we can unscrew this. I'm being very careful not to touch the connecting points with my fingers and attach this on top of my extension tubing. And I'm going to leave this in the package again so it's not dragging on the table. Next, we're going to attach our flush. So I'm going to open up my package. I'm going to take off the cap. Now these things are a little bit tricky. They're a lot of the time, under pressure. So here's a little pro tip. On a saline flush, if you will pull down a little bit, it will break that pressure. And you want to pull this all the way up and prime this all the way to the top. Okay? That way when you inject, it's not pushing air into your patient. All right, so here's our saline flush. Now we're going to attach it onto, and this is the Lurlock part where we screw this on. Now that we've attached the hub to the extension tubing, I've got my saline flush attached, and now we need to prime it. What I mean by this is I've got my saline flush, and I'm going to push the saline through the tubing, and you will be able to see how it's slowly dripping at the end. That means the saline's made it all the way to the end, so it's nice and primed for when we attach it to our patient. Now this is important to prime this, so when we attach this to our patients, it's already ready to go. Now, one little thing that you've noticed, I have left the flush on the extension set. The reason why I do this, once I insert the catheter, it's already ready to go. I can screw it on, hold pressure, and inject. So this will save me a step later, and it saves me from having to manage the flush, attach that when I'm holding on to the catheter for my patient. Hope that was helpful for you.
Now it's time to talk about the normal newborn assessment that happens about 2 hours after delivery. So we're going to talk about vital signs and how we take those, a general survey, what we look for in the newborn, and then a complete head-to-toe assessment so we can put it all together. Let's start with vital signs. Well, because we always start with vital signs. But it's particularly important for the newborn because usually at the beginning of the assessment, the baby is quiet. It is really difficult to count respirations and heart rate on a newborn when they're crying. And asking them to hold their breath or stop crying for a few minutes doesn't usually work really well. So if you start on your vital signs before you unwrap the baby, you might actually be able to hear them. Let's start with respirations. So one thing that's important to remember with a newborn is that their respiratory rate is very irregular. So you have to count respirations for a full minute. You can't cheat. So 60 seconds. It's also helpful to listen over the lung field so you can actually hear the respirations. And a normal rate for respirations for a newborn is anywhere between 30 and 60 breaths per minute. So it's a lot of quick counting, and you've got to listen over the lung fields for a full minute. Don't forget. Now on the next minute, you can also count the heart rate. Again, this rate must be counted for a full minute. The heart rate may be slightly irregular, and oh my goodness, the heart rate is very challenging to count. This is one of the most difficult skills for my nursing students because the heart rate is beating still at the rate of 110 to 160 beats per minute, just like it was in utero. So if you can imagine trying to count that, it goes by really quickly. I'm going to give you a couple hints though. You can either tap your foot, sort of like tapping your foot to the beat of the music, or you can tap your finger over the stethoscope. I have no idea why that works, but it will help you keep count. So give it a try. But remember, a full minute. So when I have a nursing student that gives me vital signs on a newborn and it hasn't been at least 2 minutes, I know they haven't quite checked it exactly like they should. So remember that. The other thing I want to remind you of when you're checking heart rate is the murmurs. So if you go back and listen to the lecture where we talked about the newborn assessment and we talked about normal fetal circulation and the closure of our ductus and closure of our foramen ovale, now those valves are still going to be moving. So that is going to create a sound, and that sound is going to be murmurs. So know that hearing murmurs on a newborn is completely normal. It's what we would expect, but you always want to report it just to make sure that there's not a complication that we're missing. So murmurs are expected, but should be reported. Now let's talk about the temperature. So typical temperature for a newborn is anywhere between 97.7 and 99.7 degrees Fahrenheit. And that translates to 36.5 or 37.5 degrees Celsius. We're typically going to also take the vital signs axillary. Now, maybe you remember from back in the day, we used to always take a rectal temperature, but we found out through evidence that we didn't really need to do that. So now, the only time you're going to get an order for a rectal temp is if the vital sign is abnormal. So if you find that you've taken an axillary temp and it's particularly low or particularly high, you may have an order for a rectal temperature. Otherwise, an axillary temperature is completely fine. Now let's talk about blood pressure. This is another vital sign that we don't check on every baby every time. We used to, a long time ago, check all 4 quadrants. So we did both arms and both legs, and we checked blood pressure on every single baby. But we realized that that wasn't necessary unless the baby was experiencing some difficulty. However, if you have an order to check a blood pressure, you can expect the range to be anywhere from 50 to 75 systolic, over 30 to 45 diastolic.
I'm going to have you stand up and kind of walk around the table, and we're going to just start taking a look at Mateo, making sure that everything is where it should be.
Okay.
All right. Kind of scared to look at that diaper, Mateo.
Would you like me to lay him down or sit him?
Let's see what he'll do. If he wants to sit for right now, I think that's fine. So for the students, I am going to listen to his heart and lungs first because he's nice and quiet right now. That might be a little bit out of order from what you would expect from a head-to-toe physical exam, but if he's crying, I won't be able to hear anything. So, oh goodness, talk to me. So I'm gonna listen to his lungs and all the fields, and they sound great. Great. Oh, I know. Do you like that? And you might need to distract the baby while you're doing the exam. All right. So I'm listening to the lung fields in the back. Make sure you give yourself time to get a good listen. Yeah. Then I'm going to come back around and I'm going to listen to the heart sounds. You want to listen in the left sternal border, the right sternal border, down, and the apex. And I don't hear any murmurs. His heart sounds great. So no concerns there. All right, Mateo. So I give a quick palpate to the head to make sure that I don't feel any deformities, any overriding sutures, anything like that. And then I come down and I palpate his sweet little cheeks and his neck. Oh, we dropped our toy. I'm gonna take a good feel, make sure I don't feel any lymph nodes. While I'm doing this, I'm looking to see if his ears look nice and symmetrical. I'm looking for any ear tags or any ear pits, which would tell me that there might be a congenital issue. Oh, you're gonna chew on my fingers, huh? Maybe got some baby teeth coming through pretty soon. I'm also gonna be looking at his eyes. I want to make sure they're properly set in his face, that they're not very low set or very wide apart or very close together. I'm looking at his little nose to make sure that I can see in both sides. And I'm looking at his mouth. So I am not opening his mouth or sticking my finger in just yet, because what I really want to do is get a look at his ears while he's nice and quiet. So, Mom, I'm going to have you, Neely, come back around here and I'll hand him to you. And I'm going to show you how to hold him so that I can get a good peek in his ears. Okay, so if you want to take a seat. All right, Mateo. And I want you to hold him facing you. All right, so Mom's got a nice good hold on him, and I'm going to get the ear speculum. We're gonna take a peek here. And now, Neely, what I would like for you to do is take this hand. Yes, and he's not gonna like it, but I want you to hold his head to you tightly.
Okay.
All right. And then sometimes I need to get up on the little stool to be able to really see. I'm going to use my finger to brace against his cheek. I'm going to pull his ear back and down. And then I'm going to take a quick peek. Oh, and they look great. And Mateo is not enjoying this exam. So can we turn his head the other way? This one's going to be a little bit easier to hold. Great. You're just gonna hold his head as tightly to you as you can. Now I'm gonna take this finger and I'm gonna brace it against Mateo's cheek because we don't want this otoscope going too far in. All right, and he let me look. So that is amazing. Often this is gonna cause kiddos to cry. Oh, there he goes. I hurt your feelings. I'm so sorry. I'm so sorry. And if the baby's crying while you're looking at the ears, it's gonna make the tympanic membranes look a little bit red. So if you can at all do it, you want to do that part of the exam while the baby's quiet. Since he's already mad, I am going to put my glove on and we're just gonna look at your little mouth. He's not gonna like this either. Or maybe he will. All right. His palate is great. He has a great gag reflex, so everything's working from that standpoint. Oh, I got some real tears. Some real tears. Now I'm going to take my light and we're going to check for a red reflex. All right. Perfect. And I'm just going to try to get a peek up those little nostrils. Again, this is not a part of the exam the baby usually likes, and you don't have to, especially if you see some snot coming out. And now I'm bracing the forehead back against Mom. Yep, looks nice and open. I don't see anything to be concerned about there. Okay. Now, let's put him on the exam table. I'll hold him for just a moment. Oh, and I want you to notice that he's appropriately looking for his mom. When I take him, he wants to know where Mom went. Oh, all right. If we can just lay him on the exam table, we can give him something to play with. Hi. Hi. Do you want that toy? Yeah. Now we're going to take a quick peek at him, kind of head to toe. Oh, I know. I know. Sometimes a medical assistant will take all of the clothes off. I usually don't require that because sometimes the exam rooms are a little bit chilly. So just expose as much of the skin as you can. One of the things that I'm looking for are any rashes or birthmarks. Are there any birthmarks that you've noticed? No. Okay. So his skin feels nice and soft. I don't feel any rashes. I don't feel any sandpapery spots. All right, I'm just going to palpate the clavicles. They feel good. All right, and I know that I've seen him move his extremities and that his shoulders are nice and open. So the next thing that I'm going to do is I'm going to listen to his abdomen. All right. So I should hear some bowel tones, and I hear quite a few bowel tones, which explains the diaper that is probably dirty at this point. All right, so that sounds great. So next I'm going to examine Mateo's abdomen. At first I want to just kind of lightly lay my fingers and see how soft it is. If it's not soft, that would be a trigger that something might be wrong. And then I'm going to get a little bit deeper. So he's probably going to tense up a little bit, but that's okay. Once I get my fingers in there, he'll relax a little bit. Oh, and everything's feeling good. I don't feel any masses, anything concerning. So I'm going to check for his liver. The way I do that is I palpate up from the hip bone until there it is. I feel the liver, and that's right below the rib cage. And then check for spleen. And looking for umbilical hernias. There's nothing poking out here, so that looks fantastic. Nothing poking out here or here where you might have an inguinal hernia. So everything on that tummy looks great. If you get a taut or a hard abdomen, or you notice anything pooching out around the umbilicus, that would be something you would need to investigate. Oh, what are you doing that? What are you doing? You're asking me what I'm doing. So after the abdominal exam, I would come do a quick GU exam, which we're going to skip for this recording. But what I would be looking for on a little boy at 4 months is the skin around his penis. I want to make sure it's nice and pink. It's not reddened. It's not broken down. I want to make sure that if the child is not circumcised, that you can pull that foreskin all the way back, that it's not too tight. And then you want to go around and make sure that his anus looks okay, that it's not reddened, that you don't see any signs of skin breakdown there. Then I'm going to make sure that our legs are moving and they're doing everything that I would expect a baby to do. And while I'm doing that, I'm looking to see if the skin folds on his legs match up. The other thing that I can do is I can put his feet on the exam table and I look to see if his knees are the same level. If all of that looks good, then that means we probably don't have a problem with our hips. And I think your hips are looking really good. So I've noticed already that there's 5 fingers on each hand. One of the things that I do is I offer him my finger, and at this point at 4 months, he still has a palmar grasp. So when you put something into his hand, he closes his hand around it. And when you do that with his little feet, when you draw your finger down the foot, then you see that those toes kind of curl in too, and that's appropriate for this age. All right, skin looks great. I'm just gonna roll you to this side so you can look at mama. I'm going to pull up here and I'm going to assess his spine. It's nice and straight. I'm looking for any kind of dimple in this area. I don't want to see a sacral dimple. Oh, we definitely have a dirty diaper. We'll get you out of that real quick, bud. No sacral dimple noted. That's another sign of congenital birth anomalies, but you look fantastic. All right. You're like, enough of this sitting down. Occasionally at this age, you might be able to elicit the walking reflex. Not yet for him. Sometimes when you put their feet on the table, they'll look like they're trying to walk. All right. But overall, Mateo, you look fantastic. All right, Nieli, he looks fantastic. I did not see anything on my exam that I'm worried about. He's meeting all his milestones. I think that we're safe to see you back at your next well baby exam, which will be at 6 months. Do you have any questions or concerns that we didn't talk about?
No.
Fantastic. All right. Well, we will have some materials for you to print out and take home because you get a lot of information during these exams and sometimes you forget. So we'll print those resources out for you, and please just let us know if you need anything in the meantime.
Okay, thank you very much.
All right. Bye-bye, Mateo.
Hello, I'm Dr. Elizabeth Stone. Now, I know that sounds formal, and when I take my students to clinical, I ask them to call me Elizabeth. So I want you to think of this video series as you and I being in clinical together. I'll guide you through the most important growth and development concepts, just like I do in my own nursing students. We're going to do this together. So today, I'm Elizabeth to you, and you're in my pediatric clinical group, which is, by the way, one of my favorite parts of being a nursing faculty. Now that we're talking about names, I'm going to use a picture of an adorable baby throughout this presentation, and Lecturio asked me to name her. Since I get to choose, we're going to call her Jenna, because that's my daughter's name. Throughout this series, we'll watch Jenna go through developmental milestones from infancy through her teen years. I'll share real-life examples from my daughter's life, and sometimes even compare her brother's experience to hers. So if you're a parent already, you can also use your child's experience to compare what I will be showing you as the normal experience. All kids are different, but it's important that you know how the majority of children develop to identify those kids who are struggling a little bit, kind of like Jenna. Are you ready? Let's get started. We're going to go through some important infant development milestones. We're going to go through weight, reflexes, motor milestones, and cognitive milestones in this growth and development series. Let's start with weight. When Jenna was born, she was over 9 pounds, and that's because she came from a healthy mother. She was born at normal gestation, so at full term, and because she was a healthy child. She had healthy genetics as well. So all of these things contribute to the birth weight. However, after birth, it's normal for every baby to lose a little bit of body weight, up to 5 to 10% in the first 10 days. But by about 2 weeks of age, they should have regained that weight and be back at least to their birth weight. They should be getting more alert. And their body weight should be rising quickly, as long as they're eating well. By 4 to 6 months of age, they should have doubled their birth weight. So that's a good rule of thumb to remember. After about the first year, their weight gain slows down, which makes sense because they're getting more active. So they're burning more calories. They gain about 2.2 kilos or 5 pounds through age 1 and 2. So that wraps up the weight. Let's move on to reflexes. Think about reflexes like survival mechanisms, and that's the same case whether you're an adult or an infant. In adulthood, actually throughout life, we have a cough reflex and a gag reflex, both of which prevent us from choking and can save our life. There are other reflexes that are appearing at birth, and then they fade away eventually throughout that first year. And we're going to go over the major ones. Let's start with the stepping reflex. This is a reflex that occurs, actually, in a way, it helps a child learn to find the mother's breast. It occurs if their feet are put against a flat surface, including if they're put on the mother's abdomen and they feel the abdomen. They start actually stepping and kind of crawling in a rudimentary way towards the breast, towards their food source. This disappears around 2 months. And then the rooting reflex is another one that's really common, especially as we try to teach infants to feed or to find the breast. If the cheek is stroked by a finger or by a nipple, they often will go towards that sensation. And a lot of times it helps them latch on to a nipple from a bottle or from a breast. This disappears around 4 months. The palmar grasp is something that a lot of people get pretty excited about, especially grandparents, as they reach out to try to hold their little newborn grandchild's finger, and the child will actually grasp it. It's actually a reflex, but you don't have to tell them that. Anything that you put in their palm when they're a young baby, they will try to grasp. This goes away around 5 to 6 months as their movements become more intentional, and then they're grabbing things that they really want. The Moro reflex is the next one, and this is kind of a funny one. They look like they're scared. So this occurs in response to a sound or a stimulus that is a touch from somebody else, or it could be even a movement that they make or that somebody else makes and they don't expect. They'll suddenly flail their arms back and put their head back, and sometimes they'll cry. And basically, it's like a startle. So Moro and startle are kind of interchanged. Those are both terms that are used for this. This reflex disappears around 2 months. And the tonic neck reflex, this is another one that has a couple different names. You may hear it called the fencing position or the fencing reflex. And this is a reflex that occurs sometimes if the child's head is turned to one side, their arm will go to that same side and stretch out, and the opposite arm will flex as if they're shooting a bow and arrow. We don't really know what that reflex really does for them, but it's kind of funny, and it's something that is checked at newborn assessments and at infant assessments as part of their neurological assessment. The plantar grasp is the last one we'll review now, and that is a lot like the palmar grasp reflex, but it's with their foot. So if their foot is stroked, the bottom of it, the plantar surface, it'll also try to grasp whatever that object is that's stroking it. And that disappears towards the age of 1 year.
Hi, welcome to our video series on nursing's neuro assessment. Now, we're going to learn so much about patients in just this simple type of assessment. So I'm going to walk you through each step of what every nurse needs to know about how to assess a patient's neurological system. Now, let's get into some terminology first. You'll see the term LOC. We abbreviate a lot of things in nursing and in the medical field, but that just means level of consciousness. And we're going to look at mentation. So when we're talking about neuroassessment, that's what we're looking at. Level of consciousness, or LOC, and mentation. So we're going to look at how the patient moves, what they can feel, that sensation, and their reflexes. Ready? All right, let's get started. Now, there's some standardized tools that we use in nursing. One is the National Institute of Health Stroke Scale. That's if we're trying to see what's going on with a possible stroke patient. Also, you'll see the Glasgow Coma Scale, or GCS. So you've got the NIHSS, and a lot of times we will just abbreviate it to that, but now you know that's what it means, or the Glasgow Coma Scale, GCS. Okay, so the Glasgow Coma Scale is based on 3 patient responses. Now, this is kind of fun because you can practice this on your roommate or one of your friends and kind of see what their Glasgow Coma Scale would be. So it's 3 patient responses: eye-opening, verbal response, and motor response. Now, how you can remember this is it's 3 words: Glasgow Coma Scale, and we're looking at the eyes, the mouth, and the motor response. Opening, verbal response, and motor response. Now, we've shown you the numbers there because patients get a score because you assess them and give it to them for their best response in each one of these areas. Then you add the 3 scores together. So we'll look at their eyes, we'll look at their verbal response, and we'll look at their motor response, and we give them a score. Add them together, and that is their total Glasgow Coma Scale score. Now, it has a range from 3 to 15. Well, that should make sense, right? Because if you gave them a 1, 1, and a 1, they would be dead. But if you gave them a 1, 1, and a 1, that would be a score of 3. If we added 4, 5, and 6 together, that would be 15. So when we say 3 to 15, that kind of gives you an idea and a reference of what we're talking about. The higher the number, the better. That's why I said if you get all 1s, that's really good in golf, not very good in the Glasgow Coma Scale. So the higher the number, the better. Now, a score less than 8 8 usually indicates a coma. So make sure you write a note to yourself that the higher the score, the better. So say 15, put a thumbs up or a star by it. And remember that a score less than 8 usually indicates coma, okay? And we're going to define coma for you a little bit later. That's a really, really bad sign. So a score of less than 8 indicates coma. That means the patient probably can't breathe on their own, so they're going to have to be intubated, where we put a special tube in their mouth and down into their airway, and we connect them to a mechanical ventilator. So someone with a score less than 8 usually cannot breathe on their own. We're going to have to intubate them and put them on a ventilator. Okay, so how many times did I repeat those things? I know, but remember, repetition is your friend when you're learning new concepts. So we know we score on 3 things. It can go from 3 to 15. The higher, the better. And a score of less than 8 means big trouble, likely to be intubated and put on a mechanical ventilator.
Let's discuss the topic of ethics, values, and nursing care. Now, while in your nursing practice, or maybe even in your clinical rotation, you may face an ethical dilemma, so we're going to discuss a little bit about this today. So before we get started, let's define actually what we're talking about between values, morals, and ethics. When we talk about values, really we define that as our own personal principles and ideas that really help us decide what's right and what's wrong. Now, this is different from morals, where this is where our actual beliefs that are formed out of our core values, and this context helps drive the rules that govern our behavior. And lastly, ethics are those moral principles that help direct our behavior and how we apply their morals. Many times as a practicing nurse, we are going to face ethical dilemmas. So the ANA Code of Ethics has provided us a framework to help us guide through those ethical dilemmas when we need to make a decision. So we're going to take a look at some nursing attributes to make sure we keep ethics at the forefront of our care. Now at the top of this graphic, you see commitment to the client. Now this seems to make a lot of sense, but many times we have our own personal values and beliefs that can sometimes impede the client's actual needs. So this is a key piece to remember, that we have to remain committed to the client. Now, promoting and advocating for the health and wellness of the client is really important in regards to ethics. And the advocacy piece is a typical action that we may need for an ethical dilemma. Now next, we are responsible and accountable for all the care that we give. Here's something we may not think about, but engaging in advancing nursing practice. Now this can mean from advancing our degree, for example, or just making sure that our knowledge base is current with the current nursing practice and the populations we serve. Now, holistically, nursing is something that we look at the dignity and uniqueness of the individual, and interdisciplinary and collaborating with our healthcare team to promote wellness is important in regards to ethical care. Now, when we're speaking about ethical dilemmas, something to keep in mind that these actually occur when values are going to conflict. Now, to resolve these, the opinions, the facts, and the values have to be identified and separated. Because practice requires nurses to respect the value of others, but also do our best to respect our own personal values. So as a practicing nurse, there are many times that you're going to run into a healthcare ethical dilemma. Here are 4 big topics that you may face in your practice. The first one being quality of life. This is going to include end-of-life care, cancer therapy, physician-assisted suicide, and do not resuscitate. One example of this is many times this is where the nurse has to advocate for their patient. Such as with cancer therapy, sometimes the patient may decide that they do not want to pursue treatment. However, the family members may feel otherwise. Again, this is where advocacy for your patient must be the forefront for their client's needs. Next is genetic screening. This could be detection of a gene that may not be causing symptoms or for which there is no cure. This may come into play with maternal nursing, for example. Now, care at the end of life. This is something personally as a nurse that I have seen and had to navigate through this ethical dilemma. So sustaining care when interventions are unlikely to sustain life. Now, some of our interventions, as you can imagine, can be invasive, and as a nurse, this is things that we consider when we're performing these on our client. Also, as a nurse, many times we're thinking about these interventions may really result in a poor quality of life to help keep the patient alive. And that's something personally and many nurses out there may have faced. And lastly is just access to health care, ensuring that all individuals have a right to care and for health and wellness and even just the resources they need to treat their illness. So talking about moral distress, this can be described as the anguish experienced when a person feels unable that they can't act according to their own values. So this is something we need to be aware of, and how do we alleviate this? Well, if we provide interdisciplinary ethics education, this can give us the knowledge base of how to better prepare how to navigate these situations. Also, just sharing those stories about professional perspectives and increasing that intercollaborative practice. And again, that's going to give you more perspectives in regards to an ethical dilemma. Now, addressing clinical situations that bring about moral distress. If you recall, we talked about those 4 big domains of healthcare dilemmas. That can be really important to talk about this beforehand because there's a good chance that you're going to face these in your practice. And of course, engaging in constructive conversations with peers or someone that you trust. Now let's talk about interprofessional collaboration. Many times when we're facing an ethical dilemma, we've got to remember that we have many people around us. So building a consensus about a specific patient case can help us make a decision and guide us when we need to do so. Also, a nurse's point of view offers a unique voice in the resolution of these dilemmas, but often these decisions are made by collaborating with others. Welcome to the very important topic of patient education. Patient education is so important in the hospital setting or in the patient care setting because this can help increase compliance with treatments and help those patients make a better treatment decision for their own care. So let's talk about some of the professional standards for client education. Now, these are set by Joint Commission, and they're also supported by your particular State Nurse Practice Act. And this client education is usually fulfilled by different members of the healthcare team. Now, let's even talk about why is even patient education such a big deal? Well, it's extremely important about ensuring informed decision making. And what I mean by this is if a patient's going to have a big surgery or an invasive procedure, they need patient education about the expected procedure and the possible risks and the benefits. It also helps to engage in their own care, and again, like we've mentioned before, it definitely helps increase treatment compliance. Because as you can imagine, if a nurse just gave you a lot of pills or a procedure to do or some sort of action and you have no idea why, well, you may not be as compliant as about making sure you stick with that treatment. And of course, patient education plays a key role in reducing injuries such as falls and increases the patient satisfaction. A lot of that has to do with patient education and just good communication. Now, one key thing to think about as a nurse is patient education is so very important of promoting excellence by supporting certain programs like congestive heart failure, stroke, or sepsis, for example. Now, what I mean by this is there's certain what we call core measures to where we have to provide specific education about that disease process for that patient. Here's a great example. Like for stroke, we have to make sure to educate our patient of what the signs and symptoms are of stroke and when to call 911 when they discharge from the hospital. This education is so very important that we educate and document. That way, if the patient goes home, they know exactly what to do and when to call 911. Now let's talk about just the pathway of education. There's those 2 big pieces of a course, teaching and the learning side. When we're talking about teaching, this should be an interactive process that helps promote learning. And there's a lot of interpersonal communication that's effective when we're making sure we keep those learners' needs in mind. Now, the learning piece is, of course, just the acquisition of that great knowledge. Now, let's talk about the role of the nurse in regards to education. We, of course, have an ethical responsibility to teach these clients. We've also got to make sure that the information that we give them is accurate, complete, and relevant to them. And we need to identify what does the client actually need to know and when are they actually ready to learn. Now, when we talk about learning, here are some factors we've got to consider when we're providing education. So number one, are they even motivated to learn? Now, this is important to assess in your patient because if this is not the time and they don't seem motivated or even willing to learn, that could create a barrier to providing education. Also consider what's their ability to learn. Are we providing education that's appropriate to their cognitive ability, their developmental level, or are they even feeling well enough because they're so ill? Are they even able to learn at this point in time? We, of course, need to assess that. And of course, think about the learning environment that you're providing education in. This allows the person to attend to instruction. Is it at the bedside, or is it maybe in a clinic setting or an outpatient setting? Now, when you talk about the learning environment, we may overlook this sometimes as a nurse, but here are some key factors to remember about a positive learning environment to facilitate education and knowledge acquisition. Can we have a well-lit environment? Also, is it ventilated? Is it comfortable temperature? Do you have the appropriate resources? This could mean online resources, this could mean a computer or even education handouts. Is the learning environment quiet? This may seem silly, I know we're in the hospital setting, but as much as possible, this and privacy is important because you want the full attention of the client. And again, sometimes all of the information with education could be hard to hear with a busy, loud environment. Of course, anytime that we provide education, we must evaluate learning. Otherwise, how do we know that that education was effective? So here are 3 great ways in making sure that our patient has understood our instructions and we can evaluate learning for them. So this first one is what we call the teach-back method. This is the absolute gold standard and one of the best ways to evaluate learning. So here's a great example of the teach-back method. Maybe your patient has to go home on a blood thinner injection that goes into their abdomen. Now, as a nurse, we're going to provide diligent education on this particular skill for the patient. Then we need to have that patient teach back to us how they would perform that skill. And of course, we will evaluate to make sure that the patient understands all those key pieces and evaluate this learning. And again, this is one of the absolute best ways and a really common method that we use. And of course, verbalizing back any type of instruction that we give them and that they understand. And written validation is another great way that if we provide education, that the patient can write out exactly what they're comprehending and the instructions that we give. Now let's talk about what is a client's preference for learning. As you can imagine, we all have different learning styles and preferences. So it's really important that you consider these and assess this before you educate with your client. So one of those is consider relevant reading materials. Now this can come in the form as like a specific, diabetic diet plan for someone who's newly diagnosed, medication information sheets, diagnosis information, or just education pamphlets. Now, some patients may really like reading materials because they've got something on hand and something they can refer back to. Also, some of your patient may be more hands-on or a visual learner. So you can use particular demonstration videos, recordings, or just hands-on activities. Now, some patients may like a really easy avenue of stuff like podcasts, internet websites that they can refer to, or online support groups where it's a non-biased place and a non-judgmental place where they can ask questions. And of course, we have educators that are specially trained to provide thorough and accurate information. A great example of that is a diabetic educator. It's a very large, complex disease process, and those diabetic educators can support them along the way.
Today, we're going to be talking about an incredibly important skill, especially for the new nurse: delegation. Imagine a brand new nurse coming into one of her very first shifts at an organization, and she has an incredible list that she has to accomplish. How is she going to get it all done? Delegation. So delegation in nursing is the transfer of the nurse's responsibility for the performance of a task to another nursing staff member, while ultimately holding accountability for the outcome. So there's several considerations to delegation. You want to think, before you delegate a skill or a task to someone else, what is the potential for harm? Can the patient get harmed in the task that you are delegating to another individual? How difficult is the task? What is the amount of problem solving and innovation required? In other words, does it require critical thinking? What is the predictability of the outcome? For example, are you going to delegate a task that could be medication to an unstable patient? You don't know what it is or what the outcome may be for that particular client? Or are you delegating a skill such as a bed bath to a stable client? And then, what is the level of patient interaction needed for the skill or the task that you are transferring or delegating to the other individual? Very much like we have rights of medication administration, we also have 5 rights of delegation. First, you want to ensure that you are selecting the right staff member, whether they are licensed or unlicensed, to delegate the task to. You have to make sure that you're delegating the right task based on the circumstances. Thinking of circumstances, what are they? What is the context around why you're delegating the task and what is going on at that particular moment? So for example, if you have a new admission coming in and you know this patient is going to be unstable and they need a full admit and they're probably going to be needing medications, when you're thinking about selecting a staff member, you would need to select a registered nurse to be able to admit the new client coming in that is possibly unstable. And so those are all 3 of these are encompassed in this one example to understand how you can select the right person with the right task under the right circumstances for that specific situation. You also want to be able to think about the directions and communication that you're giving the staff member that you're delegating the task to. Communication is clear. You need to make sure that you're giving them very clear directions on exactly what and when to do what you need to be completed. And finally, as the registered nurse, you need to be able to ensure that you're able to both supervise and evaluate the task that was completed. Now, sometimes there are some barriers to delegation. Now, why would we have any barriers to delegation? Well, first, as registered nurses, we are incredibly busy throughout our shift. So sometimes time pressures can actually prohibit us from delegating a task. It seems counterintuitive, but a lot of times when we're really busy, we just think it's easier for us to complete the task rather than to give it to another person. Similarly, when we are registered nurse, we're all registered nurses, do documentation. Sometimes when we have a lot to document, again, we feel like we don't have the time to delegate and we know that we're going to be ultimately accountable for it, so we feel comfortable completing the task ourselves rather than to delegate it to another individual. Sometimes, depending on your organization, there may be lack of education on delegation, so even seasoned nurses and new nurses may not know exactly who they can delegate tasks to or how to evaluate it. So instead of doing it, they just prefer not to delegate and they just do the skills themselves. And finally, depending on the type of care model that's adopted within your organization, depending on which team members you're working with, you may or may not be comfortable with the skills of an unlicensed assisted personnel or even another registered nurse or another licensed practical nurse because you just haven't worked with them that long. And until you've had the opportunity to work with certain team members, you may not feel comfortable delegating tasks until a relationship has been established. So there are some important aspects to effective delegation. You want to make sure that you identify the tasks for delegation based on the client needs. That's paramount. You need to be sure that what the client needs dictates what type of tasks and to whom you delegate them to. You want to ensure the appropriate education, skills, and experience of the personnel performing the delegated task. You also want to assign and supervise the care provided by others. That is your responsibility as a registered nurse. Terribly important is communicating tasks to be completed and then ensuring that you tell the person that you're delegating to report any client concerns to you immediately. You also want to organize the workload to manage the time effectively, and that holds true for you as well as to the person that you're delegating the task to. Make sure that everything is fair in regard to workload. You want to evaluate the delegated tasks to ensure that the correct completion of the activity occurred. This is really important because as a registered nurse, you are accountable for the activity that was delegated. And this gives you an opportunity to actually make sure that it was completed and to also possibly even give some peer coaching to the person that you've delegated the task to in case they need some opportunities for improvement in that area. You also want to evaluate the ability of the staff member to perform the assigned tasks for the position. And finally, you also want to evaluate the effectiveness of the staff member's time management skills. Even though you were assessing the situation at the time and you delegated a task and everyone felt that they had enough time to complete the task, that may not have been the case. So this is a great opportunity to evaluate that and to evaluate those time management skills of the staff, again, so that you can help with some peer coaching and some professional development there as well. So now we're going to do a really great example to see if you're able to figure out what type of skills someone can do or that you can delegate as a registered nurse. So your hospital patient care unit is full and it's busy with high acuity patients. The shift is somewhat short-staffed, but Susan, an unlicensed assisted personnel, and then Beth, a licensed practical nurse, has been floated in to help the registered nurses. Which of the following tasks might be delegated to Susan, the unlicensed assisted personnel? Can she assist the patient with a bath, perform an IV flush, perform a wound dressing change, collect vital signs, weigh the patient, or apply oxygen to the patient? I'm going to give you just a moment to look through those options and select more than one if possible. Select all the correct answers. So if you selected assisting a patient with a bath, collecting the vital signs, and weighing a patient, you are correct. All of these activities do fall under the scope of responsibility of an unlicensed assisted personnel. An IV flush, a wound dressing change, and applying oxygen to a patient all fall under the scope of responsibility for a licensed personnel. So it's incredibly important to remember that the nurse, the registered nurse, is ultimately accountable for the appropriateness and the supervision of the delegated task. So what did we learn today? We learned that the assignment of care to others, including nursing assistants, licensed practical nurses, and even other registered nurses, well, it's perhaps one of the most important daily decisions that a nurse makes every day. Proper and appropriate assignments facilitate quality care. If they're improper and they're inappropriate assignments, that can actually lead to poor quality of care, disappointing outcomes, and also could possibly jeopardize client safety, leading to possible legal consequences. So it's important to remember, responsibility can be delegated, but accountability cannot be delegated. The delegating registered nurse does remain accountable for client care, despite the fact that some of these aspects of care can and are delegated to others. So I hope you've had a really great time understanding a little bit more about delegation. Nursing care has certainly progressed since the days of Florence Nightingale. In fact, Florence Nightingale herself was a pioneer in the beginning stages of the advancements of infection control in healthcare by using one important skill: critical thinking. In nursing, critical thinking for clinical decision-making is the ability to think in a systematic and logical manner with openness to question and reflect on the reasoning process used to ensure safe nursing practice and quality care. Critical thinking is more complex than the everyday thoughts that fill our heads. Critical thinking implies an active application of analysis to thought processes. Now, there are a number of standards related to critical thinking and questions people may pose to themselves to aid in the critical thinking process. First, clarity. Clarity is simply the ability to think clearly and logically and to express and understand an idea in more than one medium, such as in the spoken or the written word. For example, if new guidelines are being developed, the steps involved and the supporting evidence should be clearly outlined. In seeking clarity, one might ask for more information or examples. Accuracy is carrying out tasks and treatments correctly, obtaining evidence from appropriate sources, and evaluating the evidence appropriately. For example, hospital policy may require marking a surgical site in advance with permanent ink to ensure the surgery is conducted on the proper site. In seeking accuracy, one might ask how to verify or test information. Precision is taking the time to follow steps exactly. If, for example, the nurse fails to check insulin dose with a second nurse, an error may go unnoticed. Lack of precision often occurs as a result of healthcare personnel being rushed or attempting to take shortcuts in procedures. In seeking precision, one might ask for more specific details. Achieving relevance means sorting through all of the available information and data and determine which is relevant to the situation at hand. For example, when assessing a patient with a stab wound, the fact that the patient is homeless is not relevant. Now, this does not mean that the homeless condition is irrelevant. It may be very relevant to the police or to his general health, but it's simply not relevant to this particular assessment. In seeking relevance, one may ask how this information relates to the problem at hand. Depth. Sometimes what people do is superficial, dealing with the problem at hand without looking deeper at the cause. But healthcare providers must always try to look at the complexity of a situation to determine root causes. For example, if an adolescent is repeatedly hospitalized for failing to take asthma medications, stabilizing the teen and sending her home without trying to determine the underlying reason for her failure to take medications does little to solve the problem. In seeking depth, one might ask what factors are involved in this problem and what is the best way to seek solutions. Breadth. Situations may be very complicated in medical care, so one should look at the breadth of a situation from numerous perspectives rather than just looking from one perspective only. For example, a person dying of cancer may want a do not resuscitate order while the spouse or the children may be adamantly opposed. Now, while an adult patient has the right to make this decision, family dynamics usually require that the feelings of other members also be considered. Now, the healthcare provider may be in a position to provide support and really help people arrive at a decision. In seeking breadth, one might ask if other perspectives should be considered or perhaps even alternative actions. Logic. Logic is simply the application of reason and following of logical steps. For example, the nursing process is followed in a logical progression from assessment to diagnosing the problem, to planning an intervention, to implementing the plan, and then finally to evaluating the results. Conclusions are arrived at by reviewing the evidence. In seeking logic, one may ask if something makes sense or if it seems logical. Significance. Some information or actions are more critical or significant than others. The healthcare provider must be able to exercise reasonable judgment about the significance of the information. For example, if a patient receiving a transfusion suddenly shows signs of anaphylaxis, stopping the transfusion immediately is far more significant than reporting the reaction to the physician. Issues related to significance are very common in nursing. In seeking significance, one might ask what the most important problem or central issue is. Fairness is being open to new ideas and willing to consider new or different approaches. Many of the problems in healthcare derive from an unwillingness to make changes. People become really familiar with procedures or processes and they don't want to learn new ways of doing things, even if they're better. For example, a switch to computerized charting would decrease the incidence of medication errors, but it's going to require the healthcare personnel to learn to use the new system and to learn new ways to chart information. Now, while this change would impose a burden on the staff, applying the principles of fairness meant that the benefits to the patients outweighed the inconvenience to the staff. In seeking fairness, one might ask if selfishness or personal views are interfering with fairness to others. Problem solving, decision making, and development of guidelines often begin with a review of the literature. Healthcare providers must read critically, using care to evaluate the evidence while keeping an open mind to other possibilities. The first step in the critical reading is to consider the source of the material. Juried medical journals or peer-reviewed nursing journals are always a more valid source than the popular press. Now, while this is not a guarantee that the information is correct, having the material reviewed by a number of different people really helps ensure that the most journal articles are based on solid research and that the reasoning is sound. Next, you're going to review the author's credentials. Ask yourself these questions. Who is the author or the authors? Is it a reporter, a nurse, a doctor, a researcher? One should always review the author's credentials to determine if the person is an expert in the field of study. Determine the central thesis. The thesis, or central claim of research, should be clearly stated in the introduction. One way to quickly evaluate an article or book is to read the introduction and the conclusion before the body of the text. The conclusion usually provides a summary of the thesis and the main supporting points. This is also a quick and efficient way to determine whether the material is worth reading for the purpose of study or it should be eliminated. Examine the organization and methodology. The methodology used to research or reach conclusions should be clearly outlined. If the article or book is based on a particular theory, this should also be stated. The organization of the article itself should also be reviewed to determine if it corresponds with usual practice. Ask yourself this question: does it have a clear introduction? Is it organized in a logical manner? Is there a concluding summary? Is the language and terminology appropriate for the intended reader? And next, review the evidence. Evidence is critical. The evidence provided should always support the main points of the article. And finally, evaluate. The overall article should be evaluated to determine if the content seems credible and useful. During evaluation, all the other steps in the critical review of the literature should be considered in determining if the article is sufficiently valid. So remember, critical thinking includes adherence to intellectual standards, proficiency in using reasoning, a commitment to develop and maintain intellectual traits of the mind and habits of thought, and the competent use of thinking skills and abilities for sound clinical judgments and safe decision-making. So in thinking of what we've learned today, I'd like you to consider this question. When conducting a review of the literature, what are the most important steps to follow? You're going to consider the source, you're going to review the author's credentials, determine the central thesis, examine the organization and methodology of the study, review the evidence, and then fully evaluate the article to see if it makes sense for you.
Hi, my name's Corey, and welcome to my class on hemodynamics. Hemodynamics is a very important aspect of critical care nursing and something that I am very passionate about. If you're interested in becoming a critical care nurse, I'm going to teach you the most important things to know about hemodynamics, like how to read PA waveforms and titrate medications, and prepare you to answer key questions when you're communicating with physicians. Let's get started. The first thing we're going to cover in our invasive hemodynamic monitoring is arterial lines. Typically, when we get blood pressure, we get static blood pressures from a blood pressure cuff, either on the arm or on the leg. But sometimes patients are critical and we need to have a continuous blood pressure. We do this by an arterial line that's placed directly into the artery. Usually we place it in the radial artery or the femoral artery. The femoral artery is less desirable because it's dirty, but sometimes we need quick access or the patient's anatomy doesn't allow us to put it in the radial artery. Other places we can put it in are the ulnar artery, the brachial artery, or the dorsalis pedis artery. Once we've gained access to the artery with our arterial catheter, we need to hook up a transducer and a pressure tubing to that catheter. The goal of the transducer is to take the blood pressure and then transduce it into an electrical waveform and send it to the bedside monitor. When you look up at the bedside monitor, you're going to see an arterial line waveform. The first part of that arterial line waveform is the systolic upstroke. This is the beginning of systole. When that left ventricle contracts, it causes that waveform to go up. At the very top of the waveform is called our systolic peak pressure. This is where we get our systolic pressure from. Then we have a decline in our waveform and we get what's called the diacritic notch, that little blip in the arterial line waveform. That diacritic notch is the aortic valve slapping shut. This indicates the beginning of diastolic pressure. Following this, we have another cardiac cycle in which you'll see the upstroke in the beginning of systole. When you look at the waveform in whole, you'll see a bunch of cardiac cycles. And then over to the right, you'll have your blood pressure, your systolic, your diastolic, and in parentheses underneath that, you'll have your mean arterial pressure. Okay, prior to accessing the radial artery, we need to make sure that there is blood flow through the ulnar artery. Why is that important? Well, there is a risk when we access the radial artery, we may block blood flow to the hand through that artery. Now, hopefully they'll have enough blood flow through the ulnar artery to perfuse the rest of the hand. Now, we check this with what's called the modified Allen's test. In order to do this, we place our thumb on the radial artery and our other thumb on the ulnar artery. Then we have the patient pump his hand 4 or 5 times until the hand becomes white. This indicates there is no blood flow going to the hand. Then we release our thumb on the ulnar artery and we should get blood flow back to the hand. We'll see color come back to the skin and we'll have good cap refill. This is an indication that the ulnar artery is patent and you have blood flow through that. Let's go into a complications of the arterial line. Our first complication that we may have is pain. Anytime we access an artery, we're going to cause pain to the patient. Hopefully we can do this in a controlled setting and we can give the patient some lidocaine so they don't feel it. What's important is to educate the patient on what's going on, that they'll feel pressure, and that the procedure will be quick. The next complication is infection. This is more rare than a central line infection, but it is a complication. We want to make sure that the dressing is clean and dry, or change it when it becomes saturated. Make sure that this area is as sterile as possible. The next complication of an arterial line is bleeding and hematoma. If your patient's on a heparin drip or is at risk for bleeding already, they are probably going to bleed a little bit around that catheter site, which is okay. You're just going to have to change the dressing more often. But we want to be aware that bleeding could become more profuse, or we could have a hematoma forming. If you see swelling around the area, and a lot of swelling around the area that indicates a possible hematoma, we want to take the catheter out and hold pressure and then call the physician. Our next complication is an arterial embolus. This means either we've had air go through the arterial catheter or a foreign object. This is an issue because it may block blood flow to the hand. If the hand becomes discolored or we see a large amount of air going through the catheter, we need to call the physician so that they can intervene quickly. The last complication I want to discuss here is misinterpretation of the data. This means that the blood pressure you're seeing on the monitor, the systolic, the diastolic, and the mean arterial pressure are incorrect. This can happen when the tubing is kinked, when there's air in the tubing, when there's a clot at the catheter tip, or when the transducer is not at the level of plebostatic axis. This may cause you to perform an intervention that is not appropriate for that patient and may cause patient harm. So make sure that the data that you're seeing is correct. So we talked about the misinterpretation of data. Probably the most common cause of that is your transducer. That transducer, which has a stopcock on it, needs to be in line with the plebostatic axis. The plebostatic axis is also the right atrium of the heart. It's the 4th intercostal space in the axilla line. So when you're measuring that transducer, you're gonna get it right in line with that plebostatic axis of the heart, and that is giving you the most accurate blood pressure. If that transducer is below the plebostatic axis, you're gonna have an artificially high blood pressure. And if that transducer is above the plebostatic axis, you're gonna have an artificially low blood pressure. Now, with patients, we can get the transducer to be incorrect when we're moving patients around, when we're bringing the head up or down, when we're turning the patient. Every time we do something with the patient, we need to double check that transducer and make sure that it is in line with the plebostatic axis. Also, we need to be zeroing the system to make sure that we have an accurate blood pressure as well. So after we make sure that that plebostatic axis is in line, we need to turn the stopcock up, which is off to the patient and open to air. and then we go to our monitor and we zero it out. Depending on your monitor, it may be different ways of doing this, but basically this is zeroing the system so that we're getting an accurate blood pressure. And then again, we're always checking with a manual blood pressure. If we think our arterial line is not working correctly, if we think our arterial line is dampened, always check with a manual blood pressure cuff to see if they are accurate or close within one another. If they're not, then usually you're gonna trust the manual blood pressure cuff over the arterial line pressure. Our last assessment on our arterial line waveform is our square wave test, or also called our SNAP test. In order to do this, we have to pull the flush tab fully until the waveform becomes flat and up to 300 millimeters of mercury. Once that happens, we release the flush tab and cause an audible snap to occur. After that happens, we look up at our arterial line waveform and we assess for oscillations. An optimally damped system or optimally damped waveform is 1 to 2 oscillations. If you have under 1 oscillation, you have an overdamped waveform. And if you have greater than 2 oscillations, you have an underdamped waveform. The most common alteration in our arterial line is an overdamped waveform. This is a dampening of the signal from the catheter to the transducer. This causes our arterial line to be less crisp, and we may lose our dichrotic notch. Causes of an overdamped waveform are air or bubbles in the tubing, clots at the catheter tip against the vessel wall, the stopcock could be partially closed, deflated pressure bag, tubing is kinked, or an extension pressure tubing is used but it's not the correct diameter or size. I would say the most common cause of an overdamped waveform would be air or bubbles in the tubing system. The other alteration that we have in our arterial lines are an underdampened waveform. This is an artificially enhanced signal from the catheter to the transducer. This will lead to an overestimation of systolic blood pressure and an underestimation of diastolic blood pressure. But our map should be accurate. Causes of this could be tachycardia, more of our atrial tachycardia than our ventricular tachycardias, or we have extra stopcocks added to the system. Or if we also have a very high cardiac output, we could have an underdamped waveform and we get a bounding arterial line.
Hi, welcome to our video series on dosage calculations. In this video, we're going to look at how to figure IV flow rates. Now, don't let the math scare you. We're going to give you some very clear directions and some really fun practice problems. Okay, let's start with the IV itself first. There's a primary line and a secondary line. Now, the fluid that we hang on a primary line, it's usually a larger volume, 500 milliliters or 1,000 milliliters. Now, to give you a frame of reference, a 1,000 milliliter IV bag is about half the volume of a 2-liter bottle of pop. Well, it's exactly half the volume of a 2,000 milliliter or 2-liter bottle of pop. So then we have a bigger bag and it connects directly to the patient's IV line. So you follow the primary bag, the fluid, the line, there's a tubing, all the way down, it will connect right to the patient. Now it can go to all sorts of things. We'll talk about those in our other video series, but just know for now, primary line has a larger volume, has a long line that goes from that bigger bag all the way down to the patient. Because the primary tubing is longer than the secondary IV tubing. Look at the graphic there. You see there's a much bigger box around the bigger bag and the primary tubing because it's longer, so it can connect easily right to the patient. The secondary tubing is much shorter. Now the primary tubing will have a drip chamber that's at the very top, right where it enters the bag. That's where you can see the little drips. Okay, that's going to be the fun part of our practice questions, so stay tuned for that, and we're going to give you some actual drip chamber questions that you can count. Now the drip chamber will be there. There'll also be injection ports. Thankfully, most of our tubing is needleless, so that means you can take a syringe full of whatever you need to inject to the patient and connect it directly to the port without risk of sticking yourself when you're done. It also will have a roller clamp. Now that's just a little roller that will clamp down on the tubing. The farther down you roll it, the tighter it clamps on that tubing, and the slower the drops will drip. There's slide clamps that just slide across the tubing, and that's another way to stop the flow of the liquid. Now, finally, there might be a cartridge. If this tubing is intended to go into an IV pump, which many IVs do, there'll be a special cartridge that fits the type of pump that is used in that facility. Okay, so let's start at the top one more time. Usually we have a larger volume bag. On a primary IV line could be a 500 milliliter or 1,000 milliliter. That connects to primary tubing, which connects directly to the patient. Remember, primary tubing is much longer than secondary tubing, and there'll be a drip chamber, injection ports for medication, a roller clamp to control how fast the drops drip, a side clamp to completely shut it off or open, and a cartridge on the tubing if it's intended to be used in an IV pump. Now, secondary tubing, that's the little guy, more like my size, right? It's a shorter one. Secondary tubing is shorter than primary tubing because it's just going to connect right from the pole to the top of the IV tubing. It doesn't go all the way down to the patient. Now, the medication in that secondary fluid is going to go through the primary line and it will enter the patient, but we don't have to connect the tubing directly to the patient. That's why it can be shorter. So it will also have a drip chamber, it will also have a roller clamp, and it may also have an injection port. If you look at the one in our picture, sometimes as nurses, you'll have to mix an IV piggyback or this secondary fluid volume. So it has a port where you can inject something in. Might also be done in the pharmacy. They may make this IV piggyback for you. But you've got an injection port in the secondary tubing, sometimes at the top of the bag. So you can inject whatever medication needs to go into that fluid directly into the bag. Okay, so secondary tubing is shorter, but it will likely have a drip chamber, a roller clamp, and an injection port. Now, the secondary IV lines are hung higher than the primary fluid. So take a look at that picture. You see that we have placed an extender there. That's just a little plastic hanger. You hook it through the top of the bag and put it on the IV pole. That allows the primary tubing to be lower than the secondary tubing. Okay, that's really important because that way, when it's time to hang the secondary IV bag, it will drain out first. And when it's done, then the primary fluid will just continue to drain. Because the fluid that's hanging higher has more pressure and it will empty first. Then that primary IV solution will continue to infuse after the IV piggyback or the little bag is done. Now, an IV piggyback is, we call it that because it's a smaller bag and it has a lower amount of solution in it. So you'll often see people say, give this medication IV PB. That means IV piggyback. The cool part about this is, boy, it's a lot of volume, so we can give medications over a slower period of time, lots of other fluid to kind of dilute it. Otherwise, I'd have to stand there forever with a syringe and slowly push it in. So that's what we use IV piggybacks for. They're used for intermittent medications. Can be anything from antibiotics, maybe it's a little bit of potassium, any type of medication that we give like maybe every 6 hours or every 8 hours. Now, you always want to make sure that you work with your pharmacist and make sure that whatever medication you're hanging in that secondary bag or that IV piggyback is compatible with the solution that's in the primary IV. That's really important because if you hang an IV piggyback that is not compatible with your primary solution, it could cause precipitate, or it could cause an interaction in the medications, and it could cause, if it causes a precipitate, you're going to end up with that putting right into the patient, which could cause problems with clots. So, you want to make sure they're compatible, that the medications won't work against themselves, and it won't develop something like a precipitate. Now, these volumes are usually smaller than a primary. They're always smaller than a primary. Might be as small as a 25 milliliter, 50, 100, 150, 200, or even 250 milliliters. And it will connect to the patient's primary IV tubing through the injection port, kind of near the top, but it's underneath the primary drip chamber. Remember, the injection port on an IV piggyback is right there in the bag. Often primary IV bags will also have an injection port, but when we connect the IV piggyback tubing to the primary line, it will be below the drip chamber in an injection port. Now let's talk about conversion drips to minute. Okay, so we've got normal saline at 125 mils an hour. Now, if you had a pump, you would just hang the bag, put the cartridge in the pump, and you would set it to 125 mils per hour, and the pump would make sure that that's the rate that it went. But we want you to be prepared in case there isn't a pump available. Now you may think, when would this happen? It can happen in the hospital, it can happen in certain settings, and it can also happen in the event of an emergency. So you need to know how to be prepared how to do this. So we're going to tell you that no pump is available, so the rate must be converted to drops per minute. GTT, meaning drops per minute. Okay, so look at the IV tubing and note the drop factor. Well, we know how to do that. You see the big 10 there, and it tells us 10 drops per milliliter. Okay, so we know that's what our drop factor is. This macro set is 10 drops per milliliter. So we need to convert 125 milliliters an hour to drops per minute. Okay, you with us? Let's keep going. Okay, so we've got an IV ordered to infuse at a rate of 125 mils an hour using an IV tubing set that is 10 drops, GTT, 10 drops per milliliter. Calculate the drip rate, the flow rate. Okay, so we're going to calculate the drips per minute by calculating how many milliliters per minute. It's telling us 125 milliliters an hour. Well, let's divide 125 by 60. So we're going to come up with roughly 2. Now wait a minute. I know that 125 divided by 60 isn't a perfect 2. But remember, we're doing this manually. We're counting drops. I can only count whole drops. So you're going to want to be very careful and know that I can't give 2 drops a minute. When I'm counting it using only my eyes, I can only count whole numbers of drops. I can't count 2.5 drops. I can't count 2.26 drops. I can only count 2 or 3. But since I've divided this 125 by 60, I know I'm going to go for 2 milliliters a minute. Okay, so you're going to calculate the drips per minute by calculating how many mils per minute, right? So we've got 125 divided by 60. We're all on the same page on why we can go with 2, even though we know there's a little bit of after the decimal point. The IV fluid will have to flow 2 milliliters in every minute to infuse 125 milliliters in an hour. Okay, so you still with us? Great. You understand why we're using 2 milliliters a minute, because we want to give 125 milliliters in an hour. Next step, let's calculate the drops per minute in order to get 2 milliliters in every minute. Well, we know there are 10 drops in every milliliter, right? That's what the tubing set tells us. It takes 10 drops, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, to equal 1 milliliter. So if I know 10 drops in 1 milliliter, I need to know how many drops are in 2 milliliters. Hey, even if you can already do the math in your head, don't, because I want to use this simple example as a formula. The next step would be to cross multiply, right? 1 times x and 10 times 2. So now I have 1x equals 20. So x equals 20. So I know that I need 20 drops a minute in order for me to have 125 milliliters an hour. Okay, so let's go back through that just to make sure. We got to figure out the drops per minute. So we looked at the tubing, 10 drops in a mil, and then so how many drops will it take me to have to make it in a minute have 2 milliliters? That's why we cross multiply, 20 equals x, so I need 20 drops a minute in order to turn this into a rate. Okay, so the IV fluid will flow 20 drops every minute in order to infuse 125 milliliters in an hour. So count the drops in the fluid chamber and adjust the roller clamp until you get 20 a minute. Now this is not a perfect science. It takes some practice. You're going to have to practice counting. You're going to need to have some type of watch with a second hand, and you're going to have to work with your dexterity in forcing that roller clamp back and down. Now, we don't recommend that you stand there for 60 seconds and count the drops, right? What you want to do is count for 15 or 20 seconds and then multiply it by 3 or 4. That'll tell you what you'd have for a minute. So you'll look at that chamber for a full 15 or 20 seconds. When you have that number, you multiply it to equal 60 seconds, and that will tell you what your rate is a minute. Remember, our goal is to adjust the chamber so that we have 20 drops a minute in order to get the 125 milliliters in an hour. Hi, welcome to our video series, How to Jumpstart Your Study Skills and Raise Your Test Scores. Hey, is this how your brain feels in nursing school when you think about your studying? Are you feeling overwhelmed about it? All the things that you have to do, the papers, the care plans, the exams. Well, I've been a nursing faculty for over 15 years, and I've got to have a lot of conversation with nursing students in my office. I want to sit down with you and talk about some simple strategies that you can use so your brain doesn't keep feeling like that whirlwind of books in the picture. Now, sometimes when I sit down to study, this is how I feel like. I'm frustrated, I'm tired, and no matter how hard I try, it just doesn't seem like it makes sense. Does that feel familiar? Have you sat down with your faculty and said, I studied for 45 hours for this test that I didn't pass, or I didn't get the grade that I thought I should? Well, I want to show you how to undo all that. This is what we're going to talk about in this video. If you work with me in this session, you'll be able to understand how your brain works in learning, enjoy your leisure time, and I absolutely think all nursing students need leisure time. I'm even going to share with you the research that says why you need leisure time. I want you to evaluate your current study strategies and identify new ones for you to consider. And I want to crush that fear that fuels what drags all of us down, procrastination and excuses. So you ready? Let's get started. Now, have you ever thought about yourself as being the slow kid? I always think of myself as being the slow kid. There's always that one, and you know the one I'm talking about. They sit on the front row, they have matching notebooks, they know the answer to every question. The faculty says it one time through and zoom, they got it. And then there's you in the background, trying to find a pencil, don't know where you are, don't understand the concept, and feel like you're the only one in the class who doesn't get it. Well, you may start to consider yourself the slow kid. Here's what I want to tell you. There's something really special about the way your brain works. See, look at the view of somebody who's like a race car driver, right? It's a blur. Now, we're all going to end up at the same destination. But look at the view of the hiker. What we're talking about is sometimes people who take a little bit longer to learn something have a more complete perspective of the concept. That develops a solid mastery of study. Now, so I want you to start thinking yourself as not as the slow kid. Research just tells us that you have a creative brain, and you like to look at a concept from multiple different angles to help it become solid in your mind. Remember, the goal in any subject is solid mastery. Not just memorizing facts quickly, or not just knowing the correct answer, but understanding the whys and hows between that. Because you're preparing to be a nurse who needs to be able to recognize the worst case scenario, know what to look for, and know what to do immediately in an emergency situation. So stop calling yourself the slow kid. Remember, you're going for a solid mastery of study. That means the view along your way of studying is going to be a lot more involved, but when you get there, look at all that you know. Okay, so let's first prime the pump. So I'm from the part of the United States where oil is really big business, but I want to kind of prime the pump in your head by priming your brain. I want to talk about focused brain versus diffuse brain. Now look at the picture we have up there. The thought is like the little red pinball. You pull that back, bing, and the pinball, ding, 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 bounces around. Now when I'm trying to solve a problem, like I can remember when I'm trying to do math or I was trying to do biochemistry, I would really focus and study and focus and study and focus and study. And see how the thoughts get kind of stuck in that loop? Now you need focused mode studying. That's really important. When you're trying to look at the function of the cranial nerves or all the side effects of corticosteroids, you need focused mode. But look over at the other side. Look at diffuse mode. Do you see how the relationship is? Same thought, but see how it makes much bigger patterns in your brain. Well, I want to talk to you about the differences in focused brain and diffuse brain. Because focused brain is that hyper-focus. It's very rational, it's sequential, it's analytical approaches, and you're concentrating everything right here in the prefrontal cortex. It takes an intense amount of energy. In the diffuse brain, your brain's working on things in the background. You're not actively focused on solving problems like you are in focused brain. It's more big picture thinking. And it's not associated with one area of the brain like focused brain, right here. You're using much more of your brain, more diffuse areas of your brain. Let me tell you what I'm thinking. Okay, so in focused brain, you are hyper-focused, you're really trying to get something solved. Ever tried to remember something, you just can't pull it up? Then a couple hours later, you're in the shower and you go, that's the name of that actress, or that's how that works. You get this idea. Let me give you an example from my life. When I was brand new in nursing, I was still a nursing student, just finishing up my studies. And I had to take a cardiac dysrhythmia course. Okay, so that's interpreting cardiac dysrhythmias. You know that. I went to the first day. I was all excited. I had a new notebook. I had my pen. I sat down in class. They started talking. I was lost. I didn't understand what was going on. I looked around. Other people appeared to know what they were doing, so I just kept writing notes. I went home. I was a little sad, but I thought, I'll get it better the next day. I went back the next day. Same thing. Came home, tried to study really, really hard, felt more and more confused. Went back the third day, it was no better. So I knew the test was the next day. I put all my books away. I cried. I went and just did something different. And I said, all right, if I have to stay up all night, I'm going to go ahead and look at this. I came back, I sat down, and I said, what? Well, I get it. A P wave is just going through the atrium, and the QRS is going through the ventricle. And then I've got the Q. This isn't that difficult. That's what happened. Focused brain, I kept trying and trying and trying and trying when it was so difficult and I couldn't get it. But when I stepped away, not because I knew what I was doing, because I just gave up. I stepped away for a little bit. I did some diffuse brain activity that had nothing to do with my studying. It all kind of clicked into place. See, I want to call it what trying too hard does can shut down the key areas of your brain that you need for learning. So anger or frustration shut down key areas of your brain. So when you start to feel yourself getting angry or frustrated, stop. We need a different angle. Because if you just keep going in that anger and that frustration, sometimes it isn't the most effective thing for you. Now, that doesn't mean the first time studying gets uncomfortable, you can say, whoop, too hard, I'm going to stop. That's not what we're talking about. I'm talking about when you get just frustrated or angry. That should be a key signal to you to shift to diffuse mode. Not forever, but just for a short break to kind of clean up your brain. Here's what I want you to recognize. Your mind and your brain will keep working in the background, just like apps on your phone. So when you start to feel yourself get frustrated and angry, take that as a signal to, I need a short break. I need to do something that has nothing to do with nursing or whatever you're studying, and give your brain a chance to catch its breath, to kind of reorganize itself. Now, sleep is the best diffuse brain. That gives your whole body time to recover. But a quick nap or really good sleep on a regular basis obviously helps your brain work better. It's a vital part of your memory and your learning. It lets you kind of housekeeping in your brain, kind of clean up the clutter. And it will deactivate that frontal cortex that's so active in focused thinking. Okay, so we've got focused brain thinking that you just have to do in nursing school because you're learning really difficult things. But diffuse brain time is just as important. So structured leisure time, meaning you make it a priority that you take diffuse brain time, will actually help you do better in school. Recognize when you're trying too hard, right? When you're starting to get angry and you're starting to get frustrated, you need to tell yourself, I'm not doing myself any favors here. I might need a short break. Well, this is a word I use. I don't speak German, but this word is really fun to say. I call it Einstellung. That's what I say to myself. When I find myself getting stuck and I just can't look at something else, it kind of means having a bad attitude. But when I find myself thinking like this, I just say, "Ein Stalink," because that reminds me that I'm stuck in one way of looking at a problem. I can't connect chunks. I can't put things together. So I know that I need to take a break. Because remember, neurons that fire together wire together. And that's what learning is. You are teaching your neurons to get together and have this relationship so they fire together and they wire together. Because when you first learn something, it's kind of like when you first meet a person. You're like, hey, they're kind of an acquaintance. You know a little bit about them. You have some things in common. But the more time you spend with that person, the more you get to know about them, the relationship becomes stronger. Same thing with learning. When you learn new facts and information, you kind of have this loose relationship among your neuronal pathways. As you keep studying and keep reinforcing that information, then you start to have this really tight bond between those neurons. Those that fire together, wire together. Now you can start storing information in a way that you can retrieve it, and that's what we're looking for.